and the role that digital technologies play in such public health emergencies, and particularly their increasing adoption and use during the current pandemic. The conference will also focus on digital solutions in routine care and the role of digital health in supporting continuity of care in a pandemic such as COVID-19. Some of the conference topics will include digital health initiatives and implementations for public health emergencies, clinical care and surveillance, community-level digital health solutions in public health emergencies, open source software in healthcare delivery, surveillance and public health emergencies, e-learning and digital health training for capacity building, and innovations for remote patient monitoring and care, telemedicine, among others. To participate, log on to www.ughia.org.
I'm called Nambozo Scopia. I work on Buluzwala Parish, Javazala Village. I cover 127 households. Nebonanga ba nerometi kenze busawo kubanga nebonanga batu base bali bubi mukisinza ate ni chifo kyene kino kina ke kuli ni lugudo lwesinga omutalo ale chiro lwesi balama bati bali kuyira obake kuliko ni lidwaliro da ninalometi fadali seke ni ya kenimi kesobose kubanga enyamba batu base be munane be mukisinza male sigabu makona nikakufuna mwaka guwele mwesi kwa manga corona nanika oba covid kwa manga esana nika kwana nika basa bana nika kugwa malesi mangata kwa banga kuza kuleta malesi gali kufuna masks kwafuna gloves ni sabunu nga kweza batu nga bezele babulo twakeza nengo uza kusaba ko mukono buli Yesu wama yena osi unikusaba ko mukono nga esi cyane sanire ne wajya kwirinde kawuka kano chini kakeze mukisinzi sesi manabi kitongo echo cha living goods kubanga kwa manga nena nikakutamba kuingira mukisinza kiri bana base imbasobora kubalinda bulayi malesige negesi ndeta imbawa kati andika kupendinga singi zinga linabi kugula manani malesi ni kuna chindi bude bunochi nango mwana osalwale kubude bunochi semwene ndi ni basawo base ba ipikisa ku testinga. I first test on fever, then I do a MRDT to my children.
Kirungi kusindikira abasawo mambi ne batusawo twaye dagala atudanjabira kwa abana baffe emisuja nejiwona.
These past 2 decades have seen a phenomenal change in the access and adoption of mobile and digital technology. As a result, several digital solutions have emerged. Some of these solutions are empowering people and addressing day-to-day challenges. Let's take an example of Akelo, a smallholder farmer in a rural community in Uganda. Akelo has to travel several hours to the trading center to access critical goods and services such as agro-advisory services, market information, financial services, education, even healthcare. There is only one extension worker for the whole village, which makes it hard for Akelo to get the information she needs to improve her farm yields. Not to mention the difficulty in finding market for her produce. However, after Akelo started using mobile digital platforms, her farming changed. In the absence of an extension worker, she calls a farmer's call center at no cost and gets all the information she needs. The call center links Akelo to genuine input dealers so she can order good quality seeds and fertilizer remotely. The company or service delivers the goods right to her doorstep. At harvest, Akelo gets information about where she can sell her produce at the best price. Akelo gains access to new markets, and her produce is picked from her farm and delivered to the buyers on the same platform. She gets paid through mobile money for the value of the goods sold. This helps her to keep a track record of her earnings, which can be linked to her Village Loans and Savings Association group. And thanks to efforts to link savings groups to banks, Akelo can access credit based on her savings history. Through mobile credit solutions, Akelo is now able to get access to credit on her phone, improving other aspects of her life. She can pay school fees without traveling long distances, queuing up, and in manageable installments so that her son can stay in school. Akello also accesses nearby healthcare services from health workers supported by a digitized community health structure. However, the use of these digital solutions is not always seamless. Akello sometimes has trouble with internet network as she is deep in the rural area. Electricity isn't yet available in her village, so charging her phone is not easy. In addition, all the menus and options on the phone can be confusing for Akello. As a result, Akello sometimes can't order her inputs on time or receive orders from potential customers on time. Additionally, fees and taxes make it more expensive for her to use the service. While Akello owns a mobile phone, this might not be the case for other farmers, especially women. Using a market system development approach, UNCDF is working to ease the challenges that people like Akello face. By ensuring that there is supply and demand of digital services, UNCDF aims to achieve inclusive digital economies that support women, youth, refugees, migrants, and MSMEs to thrive. Working with mobile network operators, UNCDF is exploring ways to ensure phones are more affordable in rural areas. The digital platforms use offline mode, which saves all the information in the app until the phone reconnects to the internet and uploads the information. Solar power has increasingly become available in rural areas to address the electricity issue. UNCDF works with partners to train people like Akello to fully utilize the applications on their phones. If several of the people in Akello's village and in other rural areas could adopt these digital solutions, more businesses would invest in Akello's village. And with improved market information, they would be able to get better prices for local produce, plus improved access to social services like health and education. Of course, for local markets to thrive, there is need for the right policies and regulatory environment. Using the Inclusive Digital Economy Scorecard, UNCDF works with government to ensure that there are right priorities to support the country's digital transformation.
Okay. Good morning, good afternoon, good evening, everyone. Welcome to our second day, our very exciting virtual Helena conference. My name is Billy Moses Billy. I will be your host this morning and the whole day. And I would like to thank you for making time again to be part of this very exciting 3 days. We have a very fully packed day. We have presentations from our friends who are local and also global. Before we get into the thick of things, this is just a small program that will guide us through the day. One is that we just have a brief recap of yesterday's event. We shall also then give a thank you to our sponsors. And then also, we noted that yesterday we did not have a chance to introduce our local organizing committee. And then we'll go through our program for the day. And then we open the first session. And this whole small program will not even take more than 5 minutes. So I'll go right ahead into the recap of yesterday. We had very exciting presentations yesterday. And like we said, we are going to post all these presentations on our website. Please take time to visit the website and download and learn, because much as you attended yesterday, you could have missed something, but it would be useful that you refresh yourself with the details of the presentations that were done yesterday. We thank all the presenters of yesterday who managed to give very insightful presentations, and it was a success from the team here and the team that also participated in the in yesterday's presentations. We would like to thank our sponsors. This is UCDF, UNCDF, Living Goods, IntelliSoft. Yeah, yes. So those are the main sponsors for the event. I would like to share my screen. And yes, and sorry, and the monitoring and the Makerere University monitoring and evaluation technical support team in Uganda. Thank you very much for making this a success. And we pray that we can always call on you next time to come again and support us. I'll go ahead and start sharing, going through the program so that we can briefly review the program for today. So the program for today stands as this. We shall have welcome remarks, which I am already doing. I also would like to encourage everyone, given that this today is a networking session, it would be useful to also introduce yourself in the chat so that we get to know you. We get to know who is on the session. Immediately after my small speech, we will have a panel session on multi-country effort to leverage PEPFAR health information systems to support our COVID-19 response. And we will have Miza, Manish, Sise, Kenneth Masenge, Shinedu, Ibrahim, Bello, and Jean, who will be discussing this topic for us. And I am excited that and look forward to a very enlightening discussion. About 11:25, we will have a lightning chat by our very own Professor Were, who will also be sharing with us. About 11:40 to 11:55, we will have a breakout session. But because for this moment, we do not have another breakout, we will be in one room. So we will not be moving out. However, excuse me. At 55 to 12:05, we'll have a breakout in room B, where we shall be talking about expanding the IHS2 best disease surveillance system to cater for COVID-19 case management. And these breakout sessions will run until 12:55, where we shall have an exhibition break. And then there we will go for lunch up to about 14 hours. And after 14 hours, we will convert back again to continue with the discussions and the insightful discussions, where we will first of all have a panel discussion, and then again, we'll break out into the different rooms. So before I get into open our first session, I would like to introduce our local organizing committee, which was chaired by the able Jonathan Mbango. Our Secretary General, Joan Nakiruka, was the secretary of the IOS local organizing committee. Our head of publicity was Mr. Aus Kalega, who was the able Aus Kalega. Deputy publicity was me, Abili Moses, who is speaking, our treasurer, Mr. Milton Kaye, our social media in charge was Ms. Priscilla Balirwa. Other members are Ms. Caroline Kamasaka, who is our current president, but she was able to support us as a member in this regard. Mr. Andrew Babigaisa was part of the ABLE team, and Mr. Haron Gichuishi, who were very instrumental in making this happen. Thank you very much, and I wish you a very exciting day and listening. For now, I would like to open our first session to invite into our first session. Okay. I'm done.
Morning, everyone. Allow me invite our speakers for this session, the panel that is going to be discussing multi-country effort for leveraging PEPFAR health information systems to support COVID-19 response. And this panel is going to be headed by Musna. Musna, you're welcome. With Manish, I see Manish is around, Kenneth is around. So you're welcome to the panel. I would say kindly take your seats, but we shall take our seats wherever we are and start right off. Musna, I'm going to be projecting from this side. Presentations, I have quite a number. You can guide on which one goes first. Thank you. Musna and Manish, over to you.
Thank you, Carol. I'm unmuted, and hopefully, Musna, you'll be unmuted soon. Well, good morning and welcome everyone to this panel. As Carol mentioned, my name is Manish Kumar, and I'm a Global Health Informatics Project Lead and a faculty at the University of North Carolina at Chapel Hill. So I'll briefly say about the panel and also introduce the panelists. The purpose of our panel is to share CDC and country-specific priorities and experiences to leverage PEPFAR investments with the goal to increase capacity for surveillance and response in COVID-19. Each of the selected countries has prioritized and will describe their work in utilizing available health information system, workforce, policy and governance structure, and other organizational resources in their efforts against the COVID-19 pandemic. It's my pleasure to introduce all of you to the panelists, Dr. Musna Mirza at the CDC Atlanta office. She has been providing technical assistance on CDC emergency operations, which included Zika, Ebola, and of course, COVID-19. And she has led the earlier work on the CareSat project that she's going to share about today. Our other panelist, Dr. Mustafa Bello from CDC Nigeria office, who has been leading the health system strengthening effort, and he manages the health system strengthening portfolio that includes health information system activities as well. And our third panelist will be Dr. Jan Salon Velez from CDC Haiti office. He's the HMS advisor and has led the implementation of electronic systems, especially the electronic medical record system called iSante. Our dear colleague from CDC Uganda office, Kenneth Senge, he's the HIS lead, and he leads the team's effort under the health information system vision that the CDC office has. And our colleague from CDC Ethiopia office, Dr. Dereze Habte, he's leading the monitoring and evaluation work for the PEPFAR CDC Ethiopia office. So we all have this in the panel here, and I promise you it will be a very dynamic and an interesting panel, which will probably lead to a great discussion, follow-up questions. So now I'll hand it over to Musna for her presentation. Musna, over to you.
Good morning and good evening. Good night for those of you who had to get up in the middle of the night or very early mornings. Thank you for allowing us to be the opening panel for this morning's session. I think we can move on to the next slide, please. So that's the name of the panel that you're sharing. This is the title of the presentation that I will be doing: PEPFAR Health Information System Strengthening and Expansion to Support COVID Support. Next slide, please. Our disclaimer, and on to the next slide, please. So I'll go through the project background and EPI curve and how our project activities overlay on that, a little bit about the COVID surveillance workflow, and then what's beyond CARES Act funding. Next slide, please. So we received our funding from this was DGHD Information Systems Group, received COVID-19 supplemental funding under the CARES Act to prevent, prepare for, and respond to COVID-19. And as you know, most of you must be aware, since the beginning of the current pandemic, PEPFAR has supported the country responses with the use of lab diagnostics and information systems. In addition, CDC has been supporting development of COVID-19 dashboards in several countries to rapidly display lab and surveillance data. Several of us decided to leverage this ongoing work, and this project proposal was put together and funding was secured, and work started on this in April 2021. The goal of our project is to support the national COVID-19 pandemic response through enhanced surveillance built on PEPFAR information systems. Next slide, please. So our project strategy is to leverage PEPFAR's existing digital health investments through the technical assistance platform, which you must have heard about during yesterday's workshops, and you'll also hear more about during today's and tomorrow's conversations. If you can go, yes, please stay on this one. Thank you. Our project objectives are to rapidly implement activities around 3 TAP core technical areas. TAP, again, is Technical Assistance Platform. The 3 core TAP areas are data integration strategies and implementation, which is the DICE, overall health information, and I'm going through these, the Venn diagram on the left of the screen. And on the yellow box, you see the DGHD CARES Act project, how our activities overlay all of these activities. Ours is a much smaller project because it's specifically about surveillance. Of course, TAP has a much bigger scope. The countries that we are working with are listed here in this table. The ones in orange are the ones that are initial focus countries. We did landscape assessment on all of these, but the initial focus countries are the ones that are in orange. Next slide, please. And sorry, one more time, go back to that last one quickly. The partners who are working with us on this landscape assessment on the entire project for 2 years are listed here. The key projects, key partners for each country are listed here. Next slide, please. So I'm going to walk you through the EPI curve. As you all know, prevent, detect, and respond. And again, to prevent, it's all the way at the bottom. Since I'm not sharing the screen, it's hard for me to point to what I'm talking about. But if it's someone who's sharing it, you can point all the way at the bottom. So prevent, detect, yes. So I am actually adapting this slide from Digital Square DATEC 2021 document. And at the bottom, you see prevent, detect, respond. And these are the phases of an outbreak, which sometimes leads to pandemic in our case. Initial detection of disease all the way on to rebuilding and strengthening. And you'll see stacked up are the clinical and public health functions during an outbreak. So if you click next, you'll see, next slide, next click, please. Yes, thank you. So you'll see the CARES Act project that we are talking about today overlay some of the key activities, overlay the different clinical and public health functions across the time frame, across the phases of the outbreak and the pandemic. Next slide, please. So here you'll see a generic national COVID-19 surveillance workflow. And you see from the bottom, all the way bottom, where you see the red arrow, this is suspect COVID-19 patient who walks into a testing facility or a screening facility, service delivery point, and a COVID-19 test is conducted. You go up, the test results available. If it's negative, you go through the right side of the screen. If you go, if it's positive, you go step up and then over to the right, and then of course provision of care. This is overall generic, not anything specific. If you click the next, please. One click and the next click, please. Thank you. So here you see where our packages, where the work we are doing is overlaid. So right at the bottom, Open MR's COVID-19 package, and then health information exchange really starts from where this source data is taken and sent to various different systems where it's needed. Analytic visualization support can be at different phases. So it's not exactly overlaid, but it's approximate to just give some idea of where we are trying to make a difference. Next slide, please. Yeah, so what next? So CARES funding is limited. It's already been, has been provided to programs. Our program started April, but many of the other programs started a few months earlier. So what's next? Not everything can be covered in this. Additional funding, PEPFAR and ARPA, has been provided and made available to the countries as well, 250 million to the Department of State to support the programs for prevention, treatment, and control. And if you look at the objectives, the key thing is to support the PEPFAR program, to support programs of prevention, treatment, control, but then bullet 2, prevent, prepare for, respond to COVID, including in COVID infection, illness, and death among PEPFAR-supported beneficiaries in health and workforce. So that's our primary focus. Of course, that forms a big chunk of the population that we're serving in the countries. And I think that is my last slide. What the last thing that I want to say is that CARES is of course focused on COVID, but that is the start. The point is from COVID onwards, anything the better prepared we are, and any next outbreak or pandemic that comes will be following the same principles. Acknowledgement, the U.S. Centers for Disease Control, Atlanta, and several country offices. And if you scroll to the following slide, we have our contacts. There are notes available with this, might be available for the attendees later on. Just click next slide, please. For questions, you can reach us at those email addresses. And I want to thank JMB, PATH, and UCSF for all the work that you've done for TAP. Thank you, and over to the next presenter.
Thank you, Mosna, Manish, and the team. And this is quite helpful information. And my question would be, after this, what next? Are there countries where you've applied this, and in your HIE, what are you exchanging in the HIE? What kind of information are you exchanging during the response? Okay, I see Nigeria is next. I'll project the slide shortly. I'm going to project. You can tell me which one is better because it's not labeled. Okay, here we go. Over to the Nigeria team. Ibrahim.
So, so thank you for, yeah, I just got the unmute signal. Thank you everyone. First, may I say many thanks for the abstract introduction and the courtesy, and of course, thanks to Musna, Tad, Manish, and other folks at CDC headquarters, Health Informatics team, and TAP for galvanizing and coordinating this multi-country collaborative session at this conference. I would also like to thank, on behalf of my team, the Helena Conference for giving us the opportunity to share our development work as we try to leverage our existing PEPFAR-supported HIs for the COVID-19 response in Nigeria. So I'll be making this presentation on behalf of my colleagues with whom we have co-authored this presentation. They are Dr. Ibrahim Dalhatu and Chinedu Anukwe. They are the Deputy Director of the Epidemiology, Strategic Information and Science Program, and of course, the lead of the Health Informatics and Systems Strengthening team, respectively. I've already been introduced as the Health Systems Strengthening focal person. As a quick overview before I dip into the slides, it is important to mention that PEPFAR Nigeria has indeed made some pretty huge dollar and time investment in the HIS landscape since about 18 years ago when it launched in Nigeria. And it will be difficult to put a correct dollar value to the volume of this investment because of the model of HI support that PEPFAR Nigeria has provided, which is through the comprehensive service delivery implementing partners. Of course, there have been also some central above side HIS mechanism through which we have centrally coordinated our HIS project implementations. We have tried to cost these processes through the costing analysis with CDC headquarters, but today's presentation is not about that. So some of you will have already heard what Nigeria has done in this critical space as we try to set up endurance systems to enable us to implement and manage the massive HIV program in country in over 1,000 health facilities spread over 37 geographical entities we call the states, similar to what some of you will probably call provinces in your country. Of course, the dynamically rapid data and information demand of the HIV program has made it mandatory to set up a resilient HIS system to respond to this. May I quickly just say that very recently CDC Nigeria has crossed an important milestone by putting about more than 1 million people on treatment. So the first slide will describe this PEPFAR-supported HIS. Next slide, please. So this schema provides a succinct overview of what we have been able to do in Nigeria. Although there are other pieces that are not fully depicted here. We've been able to harmonize and build centrally, as you can see, the AMR system that capture patient level data at the health facilities. So at the moment, all CDC health facilities have been deployed with the unified AMR system we call the Nigeria Medical Records System, Nigeria MRS or NMRS for short. This was built over the open source OpenMRS platform. It is very, very interactive and facilitates clinical decision support for clinicians and patient management generally. So from the NMRS, there are several other custom line list reports that have been built, which I use for program management and reporting. But the key one is really the National Data Repository NDR XML file that generates line lists with specific variables which are sent to this centralized National Data Repository as depicted above. I'll speak on the NDR shortly. But as we all know, the OpenMRS is modular, so also is the Nigeria Medical Record System. There are other modules built into it, such as the AMR LIMS integration module that supports seamless information exchange with the laboratory information management system, as you can see on the right side. So the LIMS is a web-based interface that facilitates viral load testing by ensuring rapid processing of samples as they arrive at the PCR labs and ensures quick return of viral load results to the NMRS. I'm going to speak on the LIMS in the next slide, but it suffices to quickly mention here that each viral load result that is processed and returned to the AMR is quickly integrated into each patient's record and also forms part of the data variables that go to the National Data Repository. Still at the NMRS level, there's also the patient biometric system, which helps us to capture patients' fingerprints. So each patient's PBS data is integrated with the patient's clinical and encounter records, and it's part of the data variable components that also go into the NDR. We also have the commodity utilization module with pharmacy and laboratory component that also helps us to track ARC and test kits, supplies and utilization, respectively at the facility level. Of course, there are other additional modules that facilitate patient management, which I'm not going to dwell here. Because the NMRs was envisioned to also manage other disease programs, we're also putting up a concept to develop a TB module into it. So the National Data Repository sits nationally at the both site. It is a data lake that consumes and processes patient and facility level data as they ascend. It is agnostic and is able to receive data from any EMRs once they appropriately map to the API. I should quickly mention that aside the NMRS, which is used nationally, there is also another EMR used by our USAID colleagues in their supported facilities. They call it LAMIS, which is the Life Year Management Information System. It also sends data to the NDR. So the NDR is a national platform used by all stakeholders in the HIV business. It has an analytic engine that processes data, and it provides information dashboards at the front end for some basic program charts used by stakeholders. And these stakeholders include the PEPFAR, Global Fund, government, and of course, our implementing partners. So in a nutshell, this describes the HIS landscape. Next slide, please. Next slide. Yes, so this is the laboratory information management system schema broadly as it exchanges information with the Nigerian medical record system. I've already touched a little bit on it in the previous slide, but just to describe this complex information exchange between the NMRs and LIMS. So as you can see, it helps for the processing of eligible candidates that are due for viral load. So at the beginning, from the NMRs, you can print out or you can get a list of patients that are due for viral load. This list is provided to the clinicians. And it helps, it guides them to identify candidates that are due for viral load. So they request this viral load from each client, from the clients that are due. So again, so message is sent to the LIMS via an API, via an API that this patient is due for viral load. Now, once that is done, samples are taken, and the records are documented at the lab. The lab also uses the Nigerian NMRS with the laboratory component interface. So the data are collected, manifest from the NMR, the manifest are sent electronically to the PCR labs through the LIMS interface. So before the samples even get to the LIMS, the manifest has already reached the PCR labs. So this reduces clerical work that usually takes a lot of time, and it's really one of the key reasons why return of viral result is usually delayed. In Nigeria, there was a time we were having 2, 3, it would take 3, 4, even sometimes up to 6 months before viral results return to the health facilities for use in patient decision making for management. But with the deployment of this has really reduced the turnaround time. As soon as the test is concluded at the PCR labs, the results are immediately pulled into the LIMS system through the PCR machines, and the NMRs is able to automatically pull the results from the LIMS back into the NMRs, and then the clinician can use it to make their decision around a patient. Next slide. So I mean, the next few slides will quickly describe the COVID-19 response in Nigeria, and of course the existing tracking system that are being used. Next slide, please. Of course, very quickly, this slide describes the COVID-19 outbreak response landscape in Nigeria, screening processes for case identification through contact tracing and testing, case management as a containment mechanism, and of course the ongoing national vaccination mitigation effort. Of course, we all know this. I'm not going to dwell too much on this slide, but in the next slide, you see some of the tracking system being built to track the COVID-19 pandemic and the response effort. This platform are coordinated by the Nigerian Center for Disease Control, the NCDC. Next slides. Next slides, please. So this is the surveillance outbreak response management and analysis system, SOMAS. And SOMAS has been in use in Nigeria since the Ebola outbreaks in West Africa in 2014. It was developed and it's been managed, like I mentioned in the previous slide, by the NCDC. It is an integrated surveillance system that uses open source software designed to detect and manage disease outbreaks. It connects each level of the health system in real time, from individual informants who might identify a suspected case within a facility up to a national and regional body, such as, of course, the NCDC and the West African Health Organization that also linked to this. So as you can see, there are about 12 different users. They all have their tailored, they all have their accesses to their tailored forms, a dashboard, and of course, other features based on their role in disease surveillance. So from the citizen hotline, on the left side, as you can see, reporting a suspect case to the surveillance officer at the district state level. So all this informant screening and assessment point to relay information in a cascade process to the laboratory point of service where testing and result documentation is done. Of course, ultimately, the epidemiological, demographic, laboratory, and case management data of a case are integrated in a database that is being managed by the NCDC. So of course, from there, analytics are run and updates to key COVID-19 epidemiological parameters are provided for public access on a daily basis at another special COVID-19 microsite. Next slide. Next slide. So this is the COVID-19 public access dashboard. It is situated at the COVID-19 microsite that I mentioned earlier and provides relevant aggregate information for user. It is updated and it refreshes every 24 hours. So from that way, you can see the number of confirmed cases. This is the number as at last Sunday. Then you can see the number of active cases. You can see the number that have been discharged from treatment. You can see the number of deaths that we have recorded in Nigeria. Of course, you can also see the total number of samples tested. If you go down the dashboard, you see the sub-national units. This is arranged in order of the highest body that we have observed so far. Lagos State, FCT. So these are the state entities from Lagos down to Delta. There are about 36 of such states in Nigeria plus the federal capital. But of course, because of the SNP, this is not fully depicted. On the left side, you can see the navigation panes that you can actually go through to get some other detailed information about the COVID-19 response in Nigeria. Next slide. So I have already described this schema in the previous slide where I described the PEPFAR HIS landscape. So this is what we're trying to do to leverage these resources for the COVID-19 response. So, and this is currently done on two basic fronts. One, we're expanding the Nigerian medical record system to be able to collect case identification data relating to COVID-19 in the case identification form. And this is largely, of course, in the PEPFAR supported health facilities where EMR systems are being used. For now, it is the Nigerian medical record system. So these forms reflects the national case identification form, which is being used to capture demographic data, contacts, and other epidemiological data information. It will also be used to collect case management users data so that we're able to deduce the trajectory of symptomatic recovery and at which point a patient fully recovers and is discharged if on hospital admission. But currently, the case recovery data cannot be relied upon due to lack of the record keeping, which is largely paper-based. So hopefully once this becomes very, very fully operational, we'll be able to ascertain at every time point how many patients we have on admission and how many that have been discharged. The AMR also collects COVID-19 vaccination status of patients that are HIV co-infected. So through this, we'll be able to reduce PLHIV and non-PLHIV vaccinated, whether partially or fully. Similarly, we're also working on implementing health information exchange between the Nigerian Medical Records Center, of course, the SOMAs that I've tried to describe in the previous slide. As you can see, the linkage between the AMR and the SOMAs. So a key COVID-19 program leverage of HIV service and infrastructure, of course, is the COVID-19 PCR testing of samples in PEPFAR-supported PCR laboratories, including the use of TB GeneXpert machines. So in the same way that we have integrated the NMR's LIMS to facilitate rapid sample processing and return of viral results, this mechanism will also be deployed to ensure quick sample processing and return of results for COVID-19 tests. Of course, the importance of this cannot be oversized for rapid disease containment. Of course, and I'm sure it's the same in most other countries. The PCR labs set up for HIV is what is basically being used also to test for the COVID-19. Next slide. So again, so this is the Nigerian MRS COVID-19 model that that we're developing. It depicts the basic forms that we have currently built into this model, and the forms exactly mirror the nationally approved forms being used in the response. The forms are contact investigation form, as you can see, case identification form, and the daily contact symptoms management form. So we're working on this in close collaboration with the Division of Global Health Protection, which is a CDC unit primarily at the helm of the collaboration with host government in COVID-19 response. On the right side of the slide, you can also see there are some of the custom NMRS level reports that we're developing. From the NMRS, you'll be able to pull out reports relating to contacts, the laboratory for initial samples collected, and then the follow-up samples, case management, basic epidemiology, response daily situation reports, AP summary of COVID-19 outbreak, and of course the AP curve within the NMRS level analytics and dashboard that you can see. Next slide, please. So this slide, as you can see, broadly describes a concept of multi-disease program integration and management in one subnational unit, which is a river state. So we're trying to establish a proof of concept here, and we're working across the HIV program, tuberculosis, COVID-19, and non-communicable disease, which is the NCDs. That's hypertension, diabetes stuff, to integrate approaches for patient screening, testing and diagnosis, case management, of course, vaccination. So we'll be deploying this integrated human resource support as well as data system in an horizontal fashion, not the vertical program line that most public health programs will want to go. So we hope that through this we'll be able to manage these disease entities that have, of course, obviously come to stay with us. Of course, COVID-19 has come to stay, and we cannot continue to manage it as a vertical program as we had started with the HIV at the beginning, although we're trying to integrate that. So this is what we're trying to start pretty soon in one of the subnational units in Nigeria, Rivers State. And as you can see, the slide briefly depicts that. Next slides. Of course, what are the lessons are we learning from this? Of course, the robust and dynamic in-country PEPFAR support health informatics expertise are what we are leveraging and deploying to achieve some use case design for HIV and COVID-19 co-management. Of course, expanding that also to include tuberculosis, and other non-communicable diseases, like I mentioned in the previous slide. Through this process, we have been able to also foster some multi-stakeholder collaboration. Like I mentioned, at the beginning of my slides, you could see that the Nigerian Centers for Disease Control had their own slides that they were using to manage and track the COVID-19 response. But with what we are now doing at the PEPFAR level, through this collaboration, we hope that we'll be able to go even beyond this health information systems integration that we're trying to do to be able to co-manage this co-infection that have come with us. I guess this is the end of my slides. So my colleagues and I will be here to answer questions that you may have. Thank you.
Thank you, Dr. Bello. We'll come back to you with questions. We go to Height now. I'll project their slides shortly. And also to remind you that the panelists have each 8 minutes to make their presentations. So Haiti, over to you.
Thank you. Thank you. My name is Jean-Solon Valles. I'm the HMIS advisor for CDC. Can you hear me?
Yes, we can.
Hello,
hear
can you hear me?
Yes, please.
Yes, thank you. My name is Jean-Solon Valles. I'm the HMIS advisor for CDC Haiti. I'll be presenting you what we have done so far in Haiti to give a response to the COVID-19 pandemic from a SI perspective. I would like to thank you for this opportunity given to Haiti to present what we have done in country so far. Okay, next slide, please. So what we have done for in Haiti is in alignment with the priority of the Ministry of Health, because everything we have done to support the Ministry of Health. The Ministry of Health wants to first of all do screening and testing all suspected cases of COVID-19 in the country, and having contact tracing for the positive cases, and quarantine the positive patient, and also do the case management for the positive patient. Case management is done in 2 ways, even at the community and also at facility level. So we have done a system that can bring answers to all of the priority raised by the Ministry of Health. Next slide, please. So these are the features of our system. The system are built upon existing HIV platform. In Haiti, since 2004, we have put in place, I could say, a robust platform for supporting our HIV patient, and we are leveraging on those infrastructure to give a rapid response to the COVID-19. So when I say the existing platform, is not only the technical aspect of the platform, but also human resources we have in country, because we have human resources with some expertise, and we have leverage also on those human being to give response to the COVID. Our system is a mobile system because we have to go to the community for contact tracing. We have a mobile component of our system. The data are shared securely between all the intervention team, like the community health worker, the care provider, lab operators, everything. We have shared secure data between all that intervention team. Our system provides SMS alerts to alert decision makers when a positive case occurs in their region, in their jurisdiction. We provide SMS alerts to those decision makers. The system could work offline. We don't know, we don't need the internet to have the system working. The system could work offline, and when internet is back, we will synchronize with the central server. And of course, the system generate dashboard and analysis for decision making. Next slide, please. Okay, our system has two big components. We have a component we call COVID longitudinal, COVID long, and we have another component called COVID lab. In COVID long, it's a component where the screening, the case management, and everything is made. Health workers use tablets at the facility and community level to collect data on a symptom and sign for the suspected case. We have a health community at the airport, at the borderline, to collect information on the COVID cases. And also we have the COVID lab. The COVID lab is a update we have made on our LMIS to store the result, to centralize the result for our cases, because all the lab in Haiti cannot perform a COVID lab. There are specific lab that can do a COVID lab, and those labs, they have a mandatory agreement to post their data, to post their result into that COVID lab. So we have one single test result repository in Haiti for the COVID lab. This helps us prevent fraudulent test result, mostly for travelers. All the system, they are centralized in one single repository. Next slide, please. Okay, this is the system building blocks. In the up level, we have the HIV model, what we have done so far in HIV. In HIV, we have our EMRs, and we have a consolidated server, consolidated database called SALVE, where we have all the information for the HIV patient consolidated in one place. And from this consolidated server, we can build our aggregate reporting system to report to GAC. We build our case notification, and we have our community tools. The community tools we have is from there we can do the tracking of the lost to follow-up, interrupted patient, or patient missing appointment for HIV. We have leverage on those facilities to build our COVID response. On the lower part of the screen, we have what we have done for the COVID response. In the COVID response, we have the clinic, the screening, the contact tracing. The contact tracing is made on the model of the tracking we have on the HIV, and the referral hospitalization is made on the model of the EMR. We have modified our EMR to capture data indicator for the COVID-19 system. And we have a vaccination management, which is not a system developed by CDC, it's from MOH, and we have put in place an interoperability layer to capture result or data from vaccination management to put into the COVID long. So that is our system building block for the response to the COVID-19. Next slide, please. Okay, this is the data flow for the COVID long. The COVID long is fed by staff, hospital staff, where screening is made, by border agent health, for community health agent, and we are providing response to MOH. We are sending SMS to MOH, we are sending data analysis to MOH. And on the left side, we could see that the COVID lab and the vaccination module also, they are sharing data with the COVID long, with the COVID long system. Okay, next slide, please. Okay, this is the data flow for the COVID lab. The COVID lab is only used by the labs. all the authorized lab, they are mandated to put their result into the COVID lab. So we have one single data repository for test COVID result. So it's the way the data they are put into the COVID lab, and that COVID lab also is interoperable with the COVID long. So the result data is seen easily on the COVID long also. You can see that we have an API to do the translation to the COVID labs to the COVID longitudinal surveillance. Okay, next slide, please. So this is a sample of analysis we can do with our system. We can have the number of individual screening, the number of individual screening but not tested yet, the number of tests without result, the number of confirmed case hospitalized, and cases seen at home. And we can see also the number of cases that recover and the number of deaths. All of those analyses can be disaggregated by age, sex, comorbidity, by SNU, by any finer level of information that could be helpful for the ministry to make decisions. Next slide, please. Okay, so those are some screenshots we have put to see real-time access to the testing result, how many patients has been tested, how many have been are positive, and how many have not been positive. That is a screenshot. Next slide, please. Also, this is a screenshot of case confirmed per month. We have this per month. We can have this per SNU, per department, for commune, per section communal, per sex, for everything. Next slide, please. Okay, thank you. This is what we have done for the COVID-19 response in Haiti. Thank you. I don't know if I kept my 8 minutes. Thank you.
Thank you so much. Yeah, you try to keep within the time. I think members, please keep the question coming in. I see we have questions in the chat room, and the panelists can prepare to answer the questions after we are done. I think the next is Uganda. I'll be sharing the screen shortly, and the presenter is Kenneth Musenge. Kenneth, over to you.
Okay, thank you, Carol. Can you hear me well?
Yes, Kenneth, go ahead, we can hear you.
Carol, can you hear me?
Yes, Kenneth, we can hear you.
Carol, can you hear me?
Kenneth, we can hear you.
Okay, thank you, Carol, and thank you everyone again. Like I've been introduced, my name is Kenneth Musenge from CDC Uganda, Kampala. And again, to re-echo what most of my colleagues have mentioned, I'll also be here to share our experience of how some of PEPFAR investments have been leveraged to support, you know, the novel coronavirus disease, the COVID-19 pandemic as it broke out in the country. So next slide. So like I've mentioned, Uganda has not been any different. So when the response broke out, when the pandemic broke out, you know, even long since before we got our first case in the country in March 2020, the country had gone ahead through Ministry of Health to establish an instant management team, which had critical pillars at that time, you know,
which they pretty much continue to maintain, cutting across through risk communication, surveillance, lab, case management, all the way to the strategic information and research and innovations pillar to kind of support the national response. These pretty much continue to be active. However, the focus of this presentation is going to be through the strategic information and innovations research pillar, through which some of the PEPFAR investments were kind of leveraged. That graphic there shows our current cases. That was about 2 weeks ago, but rightly, I think the numbers have increased by about 1,000 to about 125,000 plus. So next slide. So like many countries, the start wasn't easy. I mean, and at some point countries had to start from somewhere. So it became very important that leveraging some of the existing earlier investments that had been done, not only just in health information systems, but workforce, critical workforce, especially in the informatics, critical infrastructure, like HIS infrastructure, like data hosting centers, IT hardware, came in quite handy. So through that pillar that I informed you about, the strategic information pillar that had been tasked, when it was put together, it became quite important. And at that time, they had to take stock and look at, what was really under in the country, because that time there were even no budget nationally or anything. Things were still new, and we were still waiting. No one knew what to do, but at least we had a starting point. So it was at such a time that the response team started looking at some of the investments they had in the country, and like you can see from that graphic, PEPFAR heavily invested in a lot of various user-facing systems, ranging from clinical systems and numerous of them, both based at the facility and within the community. A couple of different tools for to do reporting and M&E, platforms for logistics, surveillance, lab, just to mention but a few. So as well as, like I've mentioned, that the hosting environment, the data center came in quite handy. So it was at such a time that, not only just on the PEPFAR side, but across other supporting, partners, the bilaterals and the multilaterals, that all these investments had to come into play. So in the next slides, I'm going to quickly take you through some of 2 or 3 things that, were PEPFAR's investments that were leveraged for the response. Next slide. So basically, to take you through the approach, like I mentioned, so this whole approach was being coordinated through the different response pillars, and there were a couple of them, like I mentioned, but and PEPFAR's investments were not only leveraged for data management and reporting, but also leveraged in other pillars as well, the clinical ones and the non-clinical ones. But like I said, the emphasis of this one is basically for health information system solutions that were leveraged, and these were being coordinated through the SIRI pillar, basically to provide data systems, technical assistance to all the different response pillars. One, facilitate the centralizing of data and make it available to the national stakeholders, and most importantly, to continue supporting the learning and researching as the pandemic evolved. So, and this, the way the pillar was set up is that it composed of different small working teams, starting from data management through analytics and visualization, as well as ICT. The ICT team was basically the one which did the vetting and looking at some of the existing systems, because at that time, a lot of innovations were happening also, but also, there were vendors trying to position some of their tools and that kind of thing. So each of these team had a role to play. And like I said, they were coordinated by Minister of Health, but, they were being composed of critical skills from, within the United States government, the multilaterals like the UN agencies and numerous standing government organizations. So And our greatest strength here was really, you know, the long-standing partnership most of us had with the government and our implementing partners who were based, you know, in the lower level areas, especially as we progressed through the pandemic and implementation was being decentralized. So this became in quite handy in terms of providing technical support, especially the HR that was brought on board, the infrastructure, the leadership. I mean, most of key PEPFAR partners continue to play a great role in terms of leading some of the response efforts. So that was the kind of approach of how, you know, HIS solutions were really got selected, you know, vetted and embedded into the response. Next slide. So that particular slide, I'm not so sure people are able to see each and everything, but you know, they just tries to show you the landscape in terms of the numerous systems that are and platforms that have been deployed, you know, that have been deployed across the different pillars. Like you can see the lab case through surveillance, you know, to risk communication. But initially our critical and you'll see some of the tools and platforms that have been deployed. However, our immediate support really was into the areas of lab and as well as case management. So in the next slide, I'm going to try to talk about exactly what has happened. Next. So one of the first systems developed, you know, through PEPFAR agents that was leveraged was what we call the real-time ARV stock status monitoring system, commonly known as RAS. So the RAS was basically a tool that was initially developed basically to strengthen the monitoring and reporting of ART commodity stock status, you know, at accredited sites to aid redistribution at a time when we had erratic stock, you know, supplies within the country. But later it was expanded beyond ARV stocks to also cater for testing kits and, you know, TB drugs and a little other and more components. So the whole essence was to provide real-time stock status data aggregated by, you know, the supported facilities, right from, you know, facility level to regional to national, you know, to support decision makers and as well provide accountability and transparency in the management of these logistics. So it basically just monitors, you know, it has, the way it works, it has codes that it is an SMS-based system, which is basically composed of a mobile device that where people are able to enter into data, you know, attached to a certain data set, and that data set is coded. For instance, you know, if it's a stock status or for certain ARVs or for certain testing kits or for stocks received or stocks that have been lent out or stocks that, you know, have run out of stock. So it monitors that stock level at that facility. It is SMS-based, based on SMS-based technology, and basically it also has the capability for people to put information right directly into the DHIS2 platform where people are able to get reports on stake levels, you know, on the fly. So what happened that this was customized, like you can see on the right-hand side where I'm seeing. So we had certain data elements that were related to, you know, logistics, you know, COVID logistics, as well as, you know, results, the results that were coming from the different places where they were testing from. So this got coded and got customized within the system. So on the fly, people were able to, you know, report about test results that have been performed, you know, in that particular facility or regional districts, and then be able to provide a data report. They could also be able to provide, you know, latest talks about the test kits that they have, and this is reported weekly, as well as the stocks that are pushed from the national stores to the different facilities that are involved in the response. So that we are seeing that, you know, something that was originally meant just to look at logistics that were critical to PEPFAR was now being used for logistics as well as, you know, reporting, being able to provide data at national level. Data would be, like I said, people would key in all those details using those codes, using their simple phones or whichever phone they had, and the data would be pushed to the national DHIS2 instance. That's from where analytics could be done. Next slide. So the other one was basically how they are trying to leverage Uganda EMR for COVID case management. So the Uganda EMR is based on, it's an open MRS customization that is currently being implemented in over 1,000 HIV clinics. It's been improving over and over from the time it started way back in 2011. To right now, that's being implemented at what we call a tiered approach, that for facilities that have good infrastructure, good staffing levels and everything, it's been moved to what we call point of service data captured, and it has been customized with different workflows to capture data like at registration points, the triage points, clinical room, the dispensary, the lab and everything. But we've also kept tier 2 as a data room based kind of operation for sites that have different challenges in terms of maybe staffing or issues around power and other aspects, where they do enter data retrospectively, but it has also been augmented with a mobile app for community-based services, as services get differentiated and taken to the community. So what has happened with this is that through the PEPFAR above site mechanism, which is actually met, you've already heard about them from the School of Public Health, further customization was done to include modules for case management, case registration, case management, as well as the discharge and autopsy. So, and then this has also been integrated with the electronic lab information system, along with the result dispatch system, so that it forms a whole picture from the time somebody is tested, to the time their results come, and then they are probably admitted in and they need care, to the time probably they get a final outcome when they are discharged and everything. And this is based on forms that have been formed by the case management pillar, which is a different pillar. So these were customized into the open MRS, and like we talk at the moment, is an ongoing pilot, and there are plans to integrate this with the EADSR, which the integrated drug resistance repository, surveillance repository, so that data from different pillars, because it's the official repository where data from all the different pillars is being stored, for the epidemic intelligence. So that is a second area where investments of PEPFAR are being leveraged or improved. Next. The third one is really an area, actually it should be the fourth. I've talked about the data center, which is being used. I've talked about the RAS. I've now talked about the EMR, and now I'm talking about the viral load exchange. So the different numerous systems that are being put together, people are trying to put the efforts together to make sure that, all these systems, are integrated together so that they interoperate, so that, there's seamless flow from most of those systems you saw on slide number 4 until the data gets into the repo. So, and all this has come from the early learning we had from the viral load health information exchange, and where we had, which was built basically on between the viral load, the facility-based EMR, and then the interoperability layer, the OpenHIM as the mediator, based on a standard message that is transmitted from the patient systems to the viral systems, for both the viral load request and the resulting. So, and this has come with so many advantages, and the technical teams that are involved in this approach are trying to use a similar approach to, to make sure that there's interoperability between the electronic lab information systems, the EMR, and the different track systems, and a couple of others that are already into the system. And finally, I'll go to the last slide of what we are trying to learn out as we try to leverage this, is that one, that earlier investments, that earlier investments that are especially built on, easily customizable platforms and that are open source, really came into quite handy because of the immense technical capabilities we had into the country. So, and that's why you find, like what I mentioned at the beginning, that even when the ICT subcommittee was formed within the Siri pillar, that in initial days that even it was involved in a lot of vetting of so many tools that were being brought, so many were really left out because one, they had high dependencies on the people we are bringing them into the country. But here we had tools like DHIS2, OpenMRS, the ODK platforms, and so many others, the SOMAs and others, which teams could easily customize quickly to Ugandan context and use, but also greatly investing into infrastructure which is flexible and scalable made it easy. So, like for instance, the national data center that is also supported through PEPFAR that is set up at the Central Public Health Lab came in quite handy. It was just an issue of adding a few storage resources and other things, and then the response quickly made good use of it. And then on the good side, we've also seen that the pandemic has amplified some of the things that PEPFAR has just been has been socializing and discussing about within the national system in terms of HIE standards, HIE robust data repositories, as well as unique identification, because it continued being a challenge, and it continues to be a challenge up to now. So to where that way to PEPFAR, it's more of a win that will now have more people advocate for this, as opposed to on a PEPFAR saying, oh, we need to standardize systems, we need to establish more health information exchanges, we need unique patient identification or client identification. So the pandemic has really amplified it. That's something we're also learning, but also the availability of strong technical capability within the country really manifested within the period. And what we've learned that all it takes is coordination. You couldn't believe it, how many people out there that are being made use of in the response, especially in the area of health information systems within the strategic information pillar, that is really untapped. Raw talent that is untapped was really unearthed. And so we've learned that continuing to coordinate that and will be quite beneficial. Actually, as I talk now, there are teams being coordinated by the Minister of Health that are seated in Jinja, another district within Uganda, to actually discuss aspects of how Minister of Health can use some of these resources to support the numerous systems that they have into the country. And most important also, finally, is that coordination of investments is very critical, because all this wouldn't have been possible if investment being put into the different systems that are providing the response periods wasn't being coordinated. Otherwise, there would be too much duplication and too much things left out. Thank you so much. That's all I had to share today. Thank you, everyone. And again, thank you to our colleagues in Atlanta through the TAP mechanisms for coordinating this. Mozina and others, thank you so much.
Thank you, Kenneth and Team Uganda. Seeing that we are running almost out of time, I would request that the team answers the questions that are in the chat room as we listen to the last presentation from Ethiopia. And we'll be sharing the breakout rooms later after this presentation. Thank you. Ethiopia, over to you. Manish, who is presenting for Ethiopia, so that we unmute them? There is. Yeah. All right. Thank you.
Good morning, good afternoon, good evening, wherever you are. This is Daraja from CDC Ethiopia. Actually, most of the things have been said by colleagues from Africa and Solon from Haiti, so I will be brief as much as possible. So basically, we are trying to present the implementation of COVID surveillance and data management, leveraging PEPFAR investment in Ethiopia. And our discussion will only focus on the data management aspect. Otherwise, there has been so many systems deployed in Ethiopia for COVID-19 surveillance and data management, but I will only dwell on the data management practice through leveraging paper investment. Next slide. Yeah, I would like to take this opportunity to acknowledge, the Ministry of Health, EPHI, ICAP, and other relevant partners who were in the forefront towards achieving, COVID-19 management and response during this unprecedented situation. So the approach we used include engaging, PEPFAR team in COVID-19 surveillance. We know that we are working on HIV-related data management, but the moment the epidemic was declared as of early March 2020, PEPFAR MND team was brought on board to support, data management and surveillance-related activities for COVID-19. And the surveillance and data management was aligned with the existing public health emergency management system led by the Ministry of Health and the Ethiopian Public Health Institute. We used existing expertise and resources, as was said by Haiti team. We also used, existing resources in terms of infrastructure, and we also used our resources in terms of, human resource in expanding, data management and surveillance. And we had also regular review of data management and surveillance efforts. And we have made several course correction along the course of the implementation because it was an emergency and we have to act soon, but it doesn't mean that our approach was perfect. So we had a regular review mechanism for timely course correction. And of course, close collaboration among the health program, surveillance and data management team was instrumental. Next slide. I would like to acknowledge the Nigeria team for borrowing these graphics. So I took it from the Nigeria presentation. And basically, our PEPFAR supported systems include, electronic medical record for HIV, ART provision in around 600 plus high volume health facilities. And at the same time, we also established, HIV case-based surveillance system in around 630 health facilities, which are more or less matching with the AMR site. So, and when it comes to the national dashboard, we don't have a national dashboard for AMR data, but we have a national dashboard for our HIV case surveillance system, which is using, RedCap software. Next slide. So basically, in this slide, I want to highlight, as to how we leverage, the existing resources in terms of HIV program information system. So when it comes to the national dashboard, like I said earlier, it's more focused on the HIV case surveillance system. And we established, virtual monitoring of patients on ART in the context of COVID-19. Due to the COVID-19 situation, the ministry and regional health bureaus, demand to have a virtual monitoring mechanism for patients on ART. So we have to use, a national virtual monitoring system, taking ART AMR data from 600 plus health facilities. Although it's not directly related with COVID surveillance, we used, the AMR system for HIV program monitoring, leveraging the existing electronic medical record system. And like I said earlier, we had expertise on data visualization and data management for HIV program. So those team members were directly deployed to support, national COVID-19 dashboard development. And initially, they developed a system using Excel, which was later, upgraded to Google Studio supported national dashboard for ease of, availability at all levels and for ease of being more interactive than Excel related dashboard. And of course, we also developed, data management SOP for COVID-19 reporting, data quality, and the likes. And on the right side, like I said earlier, we were using RedCap for HIV case surveillance system. And during the early phase of the outbreak, Ethiopia was having, COVID-19 testing centrally, and we're not sure about the status of the disease, in the region. So we have to do, you know, a surveillance or a survey, a national sero survey, to understand, you know, the distribution of COVID-19 in the regions. And for this, we used the red cap system that was deployed at EPHI, which was used, you know, for HIV surveillance, but we used it for national COVID-19 sero surveillance, for ease of data collection, for ease of providing feedback instantly, and for ease of analyzing the data online real time. So these were some of the data management and surveillance related activities that we used in Ethiopia, leveraging PEPFAR resources. Next slide. As you can see, the data flow for COVID-19 is very much complex, unlike, you know, other surveillance mechanisms. It entails, you know, rumor investigation, contact tracing, protection of special population, sample collection, result notification, and you name it. So the data management team was able to produce, you know, a standard operating procedure in order that, you know, relevant data reaches to the center in a quality manner. So the standard operating procedure designed by the data management team was instrumental in coordinating the data flow from lower level to the center. And as you can see at the bottom, initially we used, you know, Excel-based dashboard, which was not interactive, but based on the need from the national and other counterparts, we upgraded, you know, the Excel-based dashboard into Google Studio-based dashboard that can easily be accessible, you know, by the policymakers, health program team, surveillance team, and even, you know, technical team at national, regional, and lower levels. Next slide. Next. I just wanted to highlight, you know, how the dashboard looks like and how it was helping, you know, the policymakers and technical team in timely decision making. So the first slide, or this slide, shows a global and country situation report depicted in the national dashboard using, you know, Google Studio that describes, you know, the magnitude, trend analysis, and the likes. Next slide. It also describes the COVID-19 epidemiology, describing, you know, the distribution of the disease by time, place, and person. It also shows trend and cumulative and disease burden by time. Next. It also describes, you know, the progress of in case detection in terms of performance of active and passive surveillance, growth factor of cases, among others. Next slide. Next. Next slide, please. Yeah, another aspect of the dashboard is COVID-19 lab test. And the last one is on COVID-19 case management, which is also very crucial in terms of, you know, understanding the admission rate by age, sex, severity of illness. It helps, you know, for decision making by the policymakers and surveillance team at EPHI. It depicts, you know, trend of admission, recovery, and death, and of course availability of emergency care equipment like ventilator and the likes. Next slide. So these are the high level, you know, lessons learned, which we share with other countries. So we use the expertise and resources in PEPFAR HIV program implementation for COVID-19 data management and health system support. They were very much instrumental in, you know, starting up the data management process, which would have been delayed if we have waited for, you know, a new team to come on board. We had also collaborative efforts with the government counterpart like the Ministry of Health, EPHI, and other implementing partners. And of course, coordination among HIV, public health emergency, and health system team was instrumental in achieving, you know, the smooth implementation of data management and surveillance. Otherwise, I would like to highlight that our government has been using different systems, including DHIS2 for surveillance and response related with COVID-19. And this presentation was not meant to cover system related support you had in terms of COVID-19. Thank you so much.
Thank you so much, Tim from Ethiopia. I think we are running behind our schedule. We are going to compile all the questions and send to the panel to give detailed responses, and we shall upload this on our website and share the link. I hope that's agreeable with all of us. And this will allow us to move on to our next session. Over to you, MC.
Thank you, Carol, for the very able way you have been able to moderate this discussion. Just like Carol has said, we have the questions that were typed in the chat room. We will compile them and then we will share them with everybody, all the panelists to answer elaborately, and then we'll share them on the site. Next on our agenda is a lightning chat from our panelist, Dr. Were. Please. Please yes. Give Dr. Were you what? Okay, thank you.
Yes, can you hear me?
Yes, we can hear you very well, loud and clear.
Perfect. Good morning, or is it afternoon? Thank you, everyone. It's exciting to be able to present. I'll try to keep to time. And I think this is a slight switch to the other conversations, because we are really starting to talk about the functional side of Helena here. For me, it's obviously very exciting to see the Uganda team put this together, because a lot of the leadership there were my students at some point. So Carol, Joanne, Priscilla, Jonathan, and everyone. It's really exciting to see everything come together. So congratulations to the team. I've been given the opportunity to talk about the Education Working Group activities for Helena, and I'm speaking on behalf of some of my colleagues. So Professor Graham Wright, Professor Frank Verbeek, Dr. Da Costa Vroom, and me as the co-chair. And I like my talks to be a bit provocative, so just bear with me for those who know me. Most of us will come to these conferences, and then the conference is done and we go away, and then a couple of years later we come back and have another conference. But in the middle, we really don't spend time to think about how the organization works and what makes the organization function. And so the presentation here is just to give a sense of some of the activities that go on behind the scene, which are activities that are conducted by members like everybody who's participating here. And so it provides a chance for everyone who's listening to this and who's part of this conference to be able to contribute beyond the conference period. My presentation is, I'm going to talk about what a working group is, talk about the activities of the Education Working Group, talk about some of the things we've done over the last couple of years, and invite you to participate in the Education Working Group activities. I hope you can see my slides, right? Can you see my slides?
Yes, we can see you, Professor.
Okay,
please go ahead.
So let's define what a working group is, and this is very, very basic so that we're on the same page. So a working group is really a network of individuals who have a shared area of interest, and within organizations like Helena, working group allows opportunities for networking and collaboration to advance the field in many ways. I don't know if many people know here, but Helena is really the umbrella organization for the National Health Informatics Associations. And so health informatics associations become members of Helena, but individual level participation within Helena can happen through participating in working group activities. And so you can join a working group and choose your level of participation. And for a lot of these health informatics organizations, the vibrancy of the working groups really reflect the level of member engagement. So if you don't have a vibrant working group, and if you don't have members engaged, you really kind of largely have an organization by name only. So it's really important to get members engaged in organizational activities. Well, no, to my understanding, and I could be wrong on this, the education working group for Helena is really, to me, the only truly functional working group within the organization, which basically leaves a lot of room for the organization to grow. The Education Working Group supports capacity building and educational initiatives in Africa in the areas of health and biomedical informatics. That's really our goal, which makes it very broad, because everybody who's participating in this, for example, is engaged in some education activities to some degree. Example of some of the areas that the Education Working Group works on, and these are a bit exclusive, is providing in-service and pre-service biomedical informatics training, developing high-degree programs in the field, developing standardized competencies, supporting workforce development, supporting the educational aspects of the Helena annual conference, and helping to disseminate educational and research products. Some of our activity highlights, and I'll walk through this really fast just because we do not have much time, is over the last couple of years, we've actually harmonized competencies of Masters in Health Informatics for the East Africa region, working with the Inter-University Council of East Africa. I'll speak more about that. We've supported education in the Francophone countries, and I'm seeing that Francophone countries are not as much represented in this conference, for example. We are participating currently in the second revision of the recommendations by the International Medical Informatics Association on the competencies for education in biomedical and health informatics. And working with South African Health Informatics Association, we've organized several educational forums. Obviously, we're involved in some research, and I'll talk a bit about some of the infrastructure work that we've done as the Education Working Group. So just briefly, and I'll fly through the next set of slides, just to highlight the activities I just mentioned. So for the benchmarks for Masters in Science in Health Informatics programs, actually many people in the East African community will be seeing this coming up in the next few months because it's being published as we speak. We conducted a comparative analysis of all the accredited master's programs to see, what the competencies were. We developed benchmarks working with the Inter-University Council, and these benchmarks have now been endorsed. So maybe by next year or so, you'll be seeing all programs that are currently underway being asked to revise their curricula to comply with the benchmarks. And new programs also will be asked by the Inter-University Council through the national commissions to comply with these benchmarks. And a lot of this work was driven by the Education Working Group members. In support for the Francophone countries, this is work done mostly by Professor Frank Verbeek. So conducting workshops on health strategic planning and health enterprise architectures in Kinshasa, helping develop a common curriculum for MSc Public Health Informatics for 13 Francophone African universities coming from 8 countries, conducting 5-day training on use of digital clinical decision support solutions for first-line healthcare workers, so nurses and people coming from multiple facilities. So again, Education Working Group members going to places in between these conferences to just support educational activities. Graham Wright, who is also the Education Working Group chair for the South African Health Informatics Association, working with GNU Health and obviously the Education Working Group, helped organize a series of educational webinars, topics like Introduction to HL7 Fire, Introduction to Free and Open Source Software in Healthcare. And these are basically topics that are of interest to everyone here, and highlight some of the activities. In terms of the ongoing recommendation revision by the International Medical Informatics Association, I think anybody who's in the academic, actually in the biomedical informatics field, really should keep track of what the International Medical Informatics Association does on the competencies that should be within the field. I put the first paper for the revision they did in 2009, and right now a second revision is happening, and members of the Education Working Group are involved actively in that process. And our big goal there is to make sure that the interests of Africa are represented, because previous recommendations have ignored region-specific needs. And so we need to make sure we have our voice in that. Pretty much anybody who's been involved in the Education Working Group activities has had their name in a paper. So if you're interested in publications, there's never a shortage of publication opportunities. I'm highlighting a couple of them here, but there are tons of papers that we work on, and anybody who wants to publish can definitely get involved. When we started, we had some challenges getting some of the things we needed to get done through the existing Helena website. So out of our own initiative, we ended up creating a website that met some of the needs that we required. So the helenanet.org website, which is to meet Education Working Group activities, supports a forum for discussion through Helena Talk, an e-learning platform, which is Helena Learn, which is an adaptation from Zoom. Helena Talk is adapted from Discourse. The e-learning platform is adapted from Moodle. The Helena Talk is adapted from Discourse. And then, of course, we have a Zoom resource which anybody here can use. So if you're interested in conducting educational activities and you are limited to your 40 minutes, you can just reach out to us, and we have a Zoom platform because we believe in the mission of supporting partners to conduct the educational activities without having to bear individual level costs. And we support social media and blogging and dissemination activities if you are interested in some of those. The bottom line is, again, like you, we are just individual members who are interested in furthering the mission of Helena and in sharing a lot of the things that are going on. And so, we hope you can join us. Now, what lessons, as someone who is involved in Helena activities on a day-to-day, have I learned in terms of growing together? I think Helena now has been around for 10 years or so, and I stand to be corrected. But what I've observed is there is very little membership involvement. And so, beyond the meetings that we have as part of the conferences, people really don't understand what happens in the background in Helena. And until the membership starts understanding those things and taking ownership of the organization, it becomes very difficult for the organization to grow. So, for example, in this slide, I say, we need to have clear structures. Those structures need to be made public. We need to have systems in place. And so, for example, when is the next election? When is the president-elect going to take over? Because I think it's been 4 years since we've had a president-elect. Am I supposed to be still chair of the Education Working Group? Because we are not sure what the term of the chair should be. Chances are I shouldn't be the chair anymore. Chances are the board is not well constituted. And so, we need to have these conversations, and it will be very interesting later on this afternoon to talk about some of these things. As related to infrastructure, if other working groups are going to be coming along, we need to be able to support these working groups as Helena, and it shouldn't be individual working groups having to create things for themselves. And then the bottom line is a lot of these things will only happen if the members and the individuals here can be involved and engaged in the activities of the organization. We especially have a lot of good young leaders, as is evident from from this conference, and even from the Botswana conference. And I think some of us old folks maybe should potentially allow the younger people to step in and enhance their careers and take leadership roles in these organizations, because they've proven that they're doers and they're fully capable. So if for example, you're interested in taking over the chairmanship of the Education Working Group, we will be in full support and will basically help a lot of the young people here grow in their careers. And then for organizations like CDCs and the country partners, I think it will be very important to provide support to enhance some of these activities in a transparent way, but also to share a lot of the things that you're doing so that they can be disseminated through the Helena platform. There are many ways to get involved in the Education Working Group. One, you can become a member, and I'm sharing a link there. You can participate in the forum discussions. You can start a discussion. You can contribute. We have an Helena Education Working Group, a Google group, which you can join. There are a couple of LinkedIn profiles that you can join. The Health Informatics Professional has tons of people who started in 2009, and then there's HelenaNet. We have a Twitter feed at HelenaNet and Facebook feed at Helena. And also there's the website. You can share a blog. I know some of you here, like Vincent in Uganda, has shared a blog in there. You can share your achievements so that we can disseminate. The hope is to transition from a place where it's just a few individuals really contributing, where everyone here, when they have a paper, when they've graduated, when they have a workshop, can just go to some of these platforms and share what they have. That's what our working group is, and we encourage you to, beyond the conference, to just contact us and join the conversation to help improve the organization. Again, thank you. I particularly want to thank the South African Health Informatics Association because the Education Working Group is pretty active and drives a lot of the things we do. Obviously, GNU Health, USAID for supporting the website, and a few individuals, so Noah Kasiti, Eva Karanja, Christine Centers, Eda Young, Milka Gesich, and Job Nyagena, who always work in the background to help some of the activities of the working group. So again, thank you. And as I said, I like to be provocative. I hope this gives some food for thought and is positively received. I'll stop there. Thank you.
Thank you, Professor Were, for the very insightful presentation and thought-provoking. I am very sure that the very many people that are attending the conference have understood the significance of being part of the Helena and also being active participants within that space, because Helena as it is, it's only visible and functional if all of us can participate in sharing information, in sharing knowledge, and seeing how we can put Helena further to become relevant to all of us who are scholars and also who are also learning to become scholars of health informatics. Thank you so much for the thought-provoking. But yet, in the afternoon, we'll be still having more discussions. Would also like to encourage everybody that is on this session to try and think out of the box. Just give me a minute, please. To think out of the box and share ideas how we can make Helena more vibrant as individual participants, as opposed to leaving it to the very few who are delivering content off the websites. Like Professor has shared, there are so many avenues you can participate. I have shared the link in our chat box. Please log on, read, see where you can participate well and become relevant to the community. Thank you. We would like to go immediately to our breakout sessions, but before, I would like to take 1 minute just to do a poll to understand how we're faring in terms of the conference. Please go down below. There is a part for polls. Yeah. Polls, yes. Please take 1 or 2 minutes to just begin answering those questions, and then we close. Yeah. Fifteen more seconds. 10 more seconds. 5 more seconds. We have only 28 people so far, 30 now. If we can make 40 people. Okay, so we will end the poll as for now. Thank you for participating. My colleagues will be doing what? We'll be sharing the breakout sessions, and then you can choose how to see it. So we had two questions. One is that the conference is meeting my expectations, and we have 52% who are strongly agreeing that the conference is meeting the expectations. We do not have anybody who's disagreeing. One is neither nor is in the middle. I would like to understand how we can help this person, but it would be good to know where he needs help or she needs help to be able to benefit from the workshop. The second question is that the conference presentations are very informative, and we have up to 74% who are saying strongly agree, and then the others 26 are saying somewhat agree. The poll was 31 respondents out of 49 participants. Thank you very much. Would like now to start to go into the breakout sessions so that we can have the. We have two rooms. Room A will be moderated by the very able Baba. And then also room 2 will be moderated by Jonathan Mpango. Thank you. I wish you very fruitful discussions in those breakout sessions. We will return here after the breakout sessions for the next agenda item. Also, we shall be in the room. Okay, thank you. Yes.
Hello, everyone. We are going to
Welcome back from our breakout session. I would like to take a few minutes so that we can then go into our next session. Our next session will be group room A will have maturity model-based practical tool to guide the development of HIV roadmap. This will be done by the Regia, and then breakout room B will be expanding a DIHS2-based disease surveillance system to cater for COVID case management and COVID vaccine data management. And this will be done by Bridget Magoba, George Odongo, and Sally. Yeah. So in a few minutes, they'll open they'll open the rooms. You can choose where to go, and then go and listen in. Thank you. So the rooms are open. Please join whatever session you would like, you're interested in, and then listen in. But keep time, because it's taking 15 minutes. All those in the main room, please go out to the different breakout sessions. We have breakout room A and breakout room B. Room A, we have a maturity model-based practical tool to guide the development of HIV data use roadmap in Ethiopia, and it's being done by Dereje. Room B is done by, is on expanding DIHS2 based disease surveillance to cater for COVID. All those just joining, please go out to the breakout sessions. Room A, room B.
Must be someone doing other things. Edwin, please go to the breakout sessions. You can choose room A. Oh, sorry, it is you. Lillian, please join a breakout room. Room A or room B. Room A is on a maturity model for HIV. Room B is for DIHS2. Thank you. Welcome, Diana. We are currently in the breakout sessions. Please choose a room, room A or room B. Room A, there is HIV maturity model. Room B, there is DIHS2. Please. Thank you. Hello, Diana. In case you're wondering what is happening, we have joined the breakout sessions. Room A has a maturity model for HIV, and room B has DIHS2. Hello, Bedri. We have broken out into the breakout sessions. You can choose either breakout room A or breakout room B. BA has a maturity mode on HIV. Room B has DIHS2. Thank you. Good afternoon, Bridget. Good afternoon, Bedri. We are in the breakout sessions. Room A, room B. Room A has a maturity mode on HIV. Room B has a DIHS2. Welcome back from the sessions, very informative session. We will go immediately to the next session, which has been highlighted as shown on the shared screen. Room A will have optimizing healthcare workforce in Nigeria, and Room B will have a role of integrated laboratory data in Kenya. Okay, so welcome back from the sessions. We will go immediately, just in the interest of time, let us just go directly to the next session. Room A will have, Baba will guide on who to on the next presentation. And room B, we will have electronic medical records. Yeah, in Ethiopia. Please move to the breakout sessions, the breakout rooms. Room B has electronic medical records. Welcome back from that session. We will immediately go into the next session. And room A has leveraging investments on electronic medical records. And then room B, landscape mapping for community health. Thank you. Please join the breakout rooms for the last session, then we break out for lunch. Thank you. Please join the last breakout session. Please break out for the last session, and then we break out for lunch. Thank you. General, can you show the other breakout rooms? Welcome back from the breakout sessions. We thank you for being patient. We've been a little bit too fast, but I think the benefit has been significant. We are breaking out for lunch for about 10 minutes, and then we can come back and then listen to the next presenter, who will be Muhini, in the main lobby. Then after we break out again for the breakout sessions. Thank you so much for being patient. I wish you a good lunch. Thank you.
Uganda.
One of the things that
Here's how digital solutions are improving the health and education sectors in northern Uganda.
one of the things that VHTs have made very clear in the conversations we've had so far is the number of registers and the number of paper-based tools that they have to work with to complete their work. This is cumbersome, this is heavy, and already they are saying a mobile phone or a digital version of the tool would take this burden away.
A VHT will go to assess a child or go to attend to a pregnant lady, but they don't have that information that is critical to be shared with the person that they are attending to. So you find that now in this application, that information has been set there. It's laid very well. So in that it guides this person as they are doing the operations, they are guided on how to do the procedures.
Community health workers, supervisors and DHOs are trained by BRAC to use the app to track cases in their community and refer cases that can be handled at the nearest health facility.
In the phone they ask how old the person is, the child. and what sicknesses the child is having. And we ask the parents how long the child has been sick, and even it is there in the phone.
In education, digital solutions are enabling people to pay school fees more conveniently.
Ever since we started using school pay, we have had a reduction in our cost of operations, because before parents would come and pay fees in school. Then after paying the fees in school, they would after them paying fees, now we would have to start balancing books at the end of the day. Then you have to rush to the bank before 5 o'clock and have the payments. Then we had to employ one full person just in charge of writing fees, which is being brought to school. Parents are now taking fees through school pay and through more banking. So on that area alone, we have saved about 2 million per term.
If I am using my motorbike, it takes me 3 hours serious riding from where from my home village. Serious riding, it is 3 hours. I must come all the way from that distance. And Access Bank, we have only in Lira here, the bank that we use. I come from a Leptong and I access the bank sometimes. I come late and I find bank is closed, and I have to pay the cost of my living in town, yet I've just come to pay school fees only. Then from there, the experience is that it delays me. It delays me so much. But school pay is quick, and you do it just right now, and you receive the message back.
Check out our other videos to see how digital solutions are being used in other sectors.
The 2021 edition of the Pan-African Health Informatics Conference will be held from the 18th to the 20th October 2021 as a fully virtual conference. The conference will be hosted by the Uganda Health Informatics Association and the Ministry of Health in partnership with Makerere University School of Public Health. The main theme for the conference was inspired by the COVID-19 pandemic and the role that digital technologies play in such public health emergencies, and particularly their increasing adoption and use during the current pandemic. The conference will also focus on digital solutions in routine care and the role of digital health in supporting continuity of care in a pandemic such as COVID-19. Some of the conference topics will include digital health initiatives and implementations for public health emergencies, clinical care and surveillance, community-level digital health solutions in public health emergencies, open source software in healthcare delivery, surveillance and public health emergencies, e-learning and digital health training for capacity building, and innovations for remote patient monitoring and care, telemedicine, among others. To participate, log on to www.ughia.org.
I'm called Nambozo Scopia. I work on Buluzwala Parish, Javazala Village. I cover 127 households. Nebonanga.
These past 2 decades have seen a phenomenal change in the access and adoption of mobile and digital technology. As a result, several digital solutions have emerged. Some of these solutions are empowering people and addressing day-to-day challenges. Let's take an example of Akello, a smallholder farmer in a rural community in Uganda. Akello has to travel several hours to the trading center to access critical goods and services such as agro-advisory services, market information, financial services, education, even healthcare. There is
Living Goods is set up to make sure that affordable healthcare reaches the vulnerable within the communities. And of course, with the advent of COVID-19 from last year, access was constrained where families and communities can't easily access facilities for safety-related challenges, amongst other things. The need for services by the VHTs, the community health workers, became much more even required. We made sure that every community health worker that continues to provide services has adequate access to personal protective equipment and also very clear protocols and guidelines to ensure that they are safe. These guidelines clearly stipulate what is required for social distancing, how they should be carrying out the work that they do, to ensure that they continue to be safe as they provide these services. But also supporting through digital tools that they're able to assess how well they are, or if they are exposed to COVID-19, we're able to see that through the application. So there were modifications.
Good afternoon, everyone. Good morning and good evening. Welcome back to the afternoon session in East African time. We are going to have our next presenter who is going to present in the main room. This is Muhin. So, and you have 20 minutes. Yes. So kindly let's keep time. And then, right, Muhin, I see you are on. So you can go on. Welcome.
Thank you so much. Good morning. For me, anyone that's calling in from Eastern time zone, it's good morning. Good afternoon, and I hear it's quite late for others, so good evening. My name is Mohini Bavsar, and I'm the Global Head of Digital Health Partnerships at Living Goods. Firstly, really want to thank the Helena conference organizers, the Uganda Health Informatics Association, Makerere University, School of Public Health and Ministry of Health in Uganda for welcoming Living Goods as a key partner for this year's Pan-African Health Informatics Conference hosted by Helena. A huge thank you also to the speakers this week who have prepared such insightful panels and given us much to reflect on to advance our digital health practice. The sessions presented yesterday and the ones that we saw today and that are planned for tomorrow really show so much that we have learned, and all of your insights are giving us tools to continue our relentless journey to transform healthcare delivery with the support of digital solutions. I guess I wanted to tell a story about why I think the key to digital transformation in healthcare is in the cultural change that's needed. And I heard a few session presenters today talk a little bit about the cultural change that's needed. So hopefully it's all in line with what we've learned so far. One of the most cited mobile revolutions in Africa is the launch of Safaricom's M-Pesa in Kenya in 2007. Now, it wasn't too long after that the mHealth Alliance was also established and brought together a community of digital health innovators. And if you look at the sort of dates, that was about 14 years ago. I started working in digital health about 11 years ago. In the early years, the initial mHealth innovations led to sort of a bubble, lots of pilots and products. And despite some best intentions to continue to support and scale these innovations, many failed and ended up in a virtual graveyard, sometimes months or even a couple years after launch. Though, of course, many continued to pivot their business models, pivot their product designs before they landed in a better place. Now, through all these learnings and mistakes, the industry has committed to doing better. And we commit to do better by building products based on human-centered design principles, by adopting iterative agile software development approaches so that we can be responsive to user needs. And of course, as we're seeing in various sessions here, we're using rigorous evaluation to measure the impacts that digital solutions have on health outcomes so that our work can be evidence-based. Now, in spite of these leading practices and developing new knowledge products, to codify our understanding, all of this is very important. There are still very few examples of how digital health solutions have scaled, and that continues to be obviously the goal. Now, I won't talk today about the reasons why certain digital solutions don't make it past a few years or don't go to scale. That's another talk for another session. As I said today, I want to talk about culture. So maybe we can go back to the mobile money story. When mobile money was introduced, it really changed how money was exchanged between people and service providers and retailers. It fundamentally changed how microeconomies functioned. And perhaps our challenge in healthcare is that we have not actually changed the way care is delivered and the way healthcare information is exchanged. And so as a result, the majority of digital health innovations today are just merely digitalizing the ways in which healthcare is traditionally delivered and the way we think about healthcare. So perhaps at best, they're incremental innovations. And in this way, we're not able to unlock the potential to deliver better care and the kind of cultural change that happened with mobile money. So I come to sort of the thesis of my talk here today. And what I would like to sort of share is that I think at the root of digital transformation is actually the necessity for cultures to transform. And in the healthcare context, when we talk about cultural transformation, it really means the way people seek care, receive care, and the way providers collaborate, deliver care, make decisions. And all of this will need to change to actually show the sustained adoption and results. The COVID-19 pandemic was a trigger that disrupted the cultural inertia of health systems, of the way providers provided care and the way people access care. And it was really a catalyst that forced almost everything we know in healthcare to change. So I'll give you 3 examples that we're all very familiar of, but just to put it in a different frame, healthcare policies around the world evolved to approve vaccines in record time and make virtual care and telemedicine more accessible. Policy making is culture making. So that's an important lever for digital transformation. Ministries of health explored transformative partnerships by working differently with ecosystem partners, inviting other ministries, private sector, and nonprofits, of course, to support and jointly design new services and new products with them. And these new ways of working are also a form of cultural change. Everyone in healthcare was forced to learn and adapt rapidly. We can see already from the sessions at Helena how much learning happened over the course of this year and even last year. And so this learning and adaptability is representative of how we're able to pivot to changing circumstances. And in this process, data really became a high value resource that would inform decisions that we needed to make to flatten the curve and to advise on our strategic plans. And so going back to cultural change, how we make decisions and how effective and reliable the decisions we make, the data is for the decisions we make, means, how predictable our decisions are. And as a part of that, this is also what defines our culture, and it is key to our long-term resiliency. So what I'd like to share here today is that, policymaking, partnerships, and data-driven decision-making that leads to more predictable outcomes were always so hard to figure out in the past, before COVID, and in general, slow to change. But COVID really created the environmental pressures that forced health systems to change these core cultural levers, which are critical for digital transformation. And perhaps if we look at the big picture, the digital health industry is maybe at another inflection point in our journey, but with different parameters to work with and a new emerging enabling environment available to us. The enabling environment for digital transformation in community health is much better today than it was before. Today, many health workers have their own phones, or at least know someone who does. In some cases, it's their children who are helping them use their mobile apps to deliver care in their communities. Generally, community health workers also have a little more digital literacy than they did before through the use of other digital products, like through social media, et cetera. And access to electricity and connectivity, which are fundamental infrastructure, is also improving, even though it's not universal. Over 40 countries in Africa have a published national digital health strategy, though of course that strategy needs support to be funded. The governance teams that are managing the execution and coordination of that digital health strategy also need to be supported. But at least some strategies are in place. Our legacy practices of investing in digital health through siloed disease areas are also shifting to move towards more integrated care models, which is all powered by architecture that allows different digital systems to speak to each other. And that's also a positive direction that we're heading in. The pandemic really showed us how quickly some were able to pivot their health programs and digital solutions to add on COVID-19 screening, switch to digital microtraining, combat vaccine hesitancy through information services, and so on. These recent success stories from these rapid pivots have hints for what it takes to build resilient, adaptable digital innovations that actually last. And I think the hints may point to the cultural underpinnings of organizations and programs. Could it be that the speed at which organizations and health programs adapted is actually a signal of the culture of policymaking, partnerships, and prediction capabilities within their teams? Now coming back to the organization I'm part of, Living Goods. Since 2007, Living Goods has been working to close the gap between the potential of community health workers to save lives and the challenges they face regularly, including insufficient training, supervision, and access to medicines. We focused on an improved model for delivering care at the last mile, which we call DESC, D-E-S-C. The letters stand for digitally enabled, equipped, supervised, and compensated. And so, as you can see from this model, digital technology is a key enabler in our work, but it's not the place where we start. The technology really supports what is defined by a strong programmatic vision for care delivery. And so based on this approach, in 2014, an RCT showed that our approach reduced child mortality by 27%. And in 2020 alone, more than 11,000 Living Goods supported CHWs assessed more than 3 million sick children using technology. And last year, we identified more than 165,000 under-vaccinated children and helped 85% of them achieve full vaccination status. Like many organizations supporting primary healthcare, we also made a number of strategic adjustments beginning in March 2020, once the first cases of COVID-19 were reported in Kenya and Uganda. Following the DESC approach, we adjusted our digital job aids used by CHWs to support them to deliver care remotely. But before that, we had to sort of make that decision that remote care was needed. We also then moved to equipping CHWs with PPE and provided free medicines, and we modified our compensation structure for CHWs to reflect the change in activities and their work. We tested two-way messaging for information campaigns to community members we served, and we also have a lot more learning to do in terms of how do we better support our programs to adapt to blended learning options of in-person and remote. In a nutshell, we deployed nearly 6 innovations, both digital and programmatic changes in 2020 in a matter of 8 months. That's an average of about 1 new innovation every 6 weeks. In 2021, this year, we continued our adaptations to include support for CHWs to mobilize communities they serve to take up the COVID vaccines as they become more available. Again, following our DESC approach, our digital change was accompanied by supportive changes to training, supervision, and compensation structures. So we don't support the digital solutions in our programming in isolation. It's always in combination with other programmatic elements. Our existing culture for innovation and adaptation allowed us to make these pivots during the pandemic, and our new strategic vision will be focused on what we believe is a new frontier of impact, which will build strong relationships with government to improve health outcomes through national governments and help governments truly own the process of reinforcing and transforming national community health programs. And in this way, we aim to help 35,000 CHWs reach their full potential. Now, coming back to digital transformation in healthcare is a really ambitious goal. It's a long journey and requires significant capital investments. The innovation mindset through open policy making, transformative partnerships, and improving data-driven decision-making and better predictions catalyzed during the pandemic may be the window to actually enable digital transformation to take root with greater probability to succeed. And the stakes are much higher now too. With the pandemic still looming, vaccine supplies lacking, and decades of progress made in global health on the continent that have been set back. The big questions ahead of us are how we can sustain the new ways of working for policymaking, partnerships building, and data use for prediction that we've demonstrated through these environmental pressures caused by the pandemic for sustained impact and change as we manage the COVID-19 going forwards. As technologists, health informaticians, and enablers of technology use in healthcare, what can you do individually to support the cultural change needed for digital transformation? Well, there are many things you can do, but one specific thing you can do is to help demystify the technology and the ways in which it's been proven to support healthcare delivery so that we can bring our healthcare leaders closer to us as informed thought partners and designers in this journey. And instead of sort of taking a digital first, virtual first, offline first approach, if we can make this conversation and this journey more about health first this time around, we may be able to create the cultural change we need to begin to have an opportunity for sustained innovations that'll last us much more beyond the pandemic itself. Thank you so much for your time and attention and the opportunity. I'd love to hand it back to the chair and open up for questions.
Thank you, Mohini, for the very enlightening presentation. We will be moving into our next breakout sessions, but I would like to encourage everyone. Where are we going to? So, let me just confirm. Which will include Rana, Godfrey Kadewele, Rami, and it will be moderated by Tom. Over to you, Tom. But before we go to Tom, I would like to mention that in case you have any questions for Mohini, please do type them in the chat, and then we will pass them to her. She will be able to give an elaborate response to the questions, and we will post them on our website where you will be able to find the answers to them. Thank you very much. But also before we go, I wanted to mention that we would like to invite you to stay around a little longer for the Helena General Assembly, which will be one of a special session to discuss how Helena is working, and it will be good for you to understand how Helena and how you can participate. Just to reiterate what Professor Were had earlier indicated. Thank you. It will only take about 15 minutes. And so we will expect that everyone can come in. Over to you, Tom, please.
Hello, can everyone hear me?
Yes, we can hear you.
Should I start sharing my screen? I was not sure.
Yes, please go ahead and start sharing your screen and then present. Okay. Thank you.
Okay, thank you. Let me know if you can see my screen.
Yes, we can see your screen.
Okay.
Projection mode. Thank you.
Thank you, everyone. Thanks for the opportunity to be part of this conference. I would like to thank all the panelists, esteemed panelists, for agreeing to be on this panel. And extremely sorry for the delay. We have panelists from USAID, Pakistan, Malawi, and Rwanda. I just wanted to spend a couple of minutes setting context on what our panelists would be sharing about, so that the participants are aware and gives some context for that discussion. One is the supply chain information systems maturity model. In one of the panels yesterday, we discussed in depth about this tool. But the reason I wanted to highlight it before our panelists start sharing about this was the importance of looking at supply chain information systems holistically, because the processes are interconnected. So it's important that changes being made in one system, we understand the impact that it would have on other systems. The other, and you can find resources about this tool on the website links provided here. And I believe the slides will be shared after the conference. The other initiative, which is also key, is the product master data management. And all the participants, especially from the country, the panelists, they have taken up important initiatives to implement product master data management, which is really the foundation for supply chain systems and important to help adopt standardization across countries. So without much further ado, I'd like to introduce the first panelist, Dr. Rami Girgis. Dr. Rami Girgis is the Senior Information Technology Advisor at USAID. In his current role, Dr. Girgis advises countries with respect to the automation of their national level public health supply chain systems. And he also has oversight on USAID's global MI systems for supply chain. So over to you, Rami. If you can please unmute Rami.
Thanks, Sarup, and yeah, thanks for the Helena organizer. So quickly in the next few minutes, I would like to go and talk more about one of the main foundation things for supply chain digital transformation, which is mainly about the adapting the standards and the national based product catalog. So if we can go to the next slide. Yeah, so one of the issues that we are currently seeing that we start to have several information systems supporting regulatory bodies, supporting supply chain, supporting health information system, and each of these systems have their own product identifier that they are not connected, which make it very difficult to connect this various system in terms of identifying what product we are addressing. Next slide. We have also, we also have the same issue, not only at the country level, but also at the global level with each of the donors. When they procure and deal with commodity, they have their own different identifier, which again, they are not, this identifier are not linked together, and it's making it difficult to have more of holistic understanding and of the product and what it's mean. Next slide. So this lack of standardization in product identifier is one of the starting issues that need to be addressed in order to enable digital transformation for supply chain. Because currently with the lack of standardization product identifier, it results in an inaccurate planning with different identifier in the different systems. It's difficult to compare between how product is defined in one system versus the other. It also results in inefficient operation where now we can see we have majority of the product that is barcoded based on the global standards, but at the same time we cannot leverage and use this barcode in the packages. We also have a problem in terms of interoperability between these various systems. It will make it more difficult to track and trace commodity, and of course this is all resulting in a poor end-to-end data visibility. And next slide, please. So in general, we still, like, even if there is a lot of progress moving on now, but we still see in digital health, we can see fragmentation, duplication, and lack of interoperability. And again, as I mentioned, this is the situation in few years. There is a lot of progress trying to addressing this issue, but it's still, we can see still the duplication and fragmentation. Next slide. So one of the key foundation of for addressing this issue is to have a standardized based product master and product identifier. And the idea here that this standardized product identifier is defined by the manufacturer and then be shared and used in the same way all across the supply chain with all of the stakeholders and with all the entity that is dealing with health commodity. which we refer to as a product master, which include both the product identifier and all of the related information about the product, which we call them the product attribute. So this is highlight here the importance and the concept of having one product master that again is created and owned from the manufacturer, from the creation of the product, and then be used all across the supply chain. Next slide. So this is where we came to the importance to have a standardized based national product catalog in countries where it can be mainly the authoritative source of the standardized product identifier and the standardized attribute. And one of the most common standard in supply chain is the GS1 standard, and it is not just one standard, it's a set of standards where you have standards for identification, you have standards for how to capture data, how to share data, and then how to use it. The National Product Catalog, when it's standard-based, this is where it is a foundational and one of the first steps toward achieving digital transformation, where you can have the identification piece, identifying of the product, where you also can have capturing it through the standardized barcode. So in this case, what we call it automatic identification and data capture. So it can enable having the barcode where you can scan the barcode, you can understand what is this product. It also can help interoperability between the various systems. So as the health commodity go through one system to another, they all will have all of the system will have the same understanding about what is this product. And even in the case if they have different internal identifier, we can National Product Catalog can help in doing the mapping. So at least you can and the translation as the physical commodity is moving, you can also ensure that the data flow is moving with the physical flow. And then, of course, once you have this foundation, there will be a whole set of application and use that you can achieve from having traceability, from having end-to-end data visibility. But again, even if it may be simpler, but definitely having a standardized identification is and adopting of the standard is very, very key component to enable the supply chain digital transformation. Next step. So, and the idea here that this is not just for supply chain, but this National Product Catalog will be basically the authoritative source for this standardized data that it can be used across all of the systems. So if you can see here from the right side, in any country, you can have a set of transactional system, whether they are the warehouse management system, ELMSs, health information system, regulatory system, traceability, registration, all of them will be accessing the National Product Catalog and utilizing standardized product identification, which can help the interoperability between them. Next slide. And several countries for health information system in general, they have been adopting the open HIE architecture. And within the open HIE architecture, they have a standardized registry, like they have the master facility list for dealing with the standardized location identification. There is also here the product registry, which the National Product Catalog can serve as the product registry under the open HIE architecture. And again, this is where we believe that the product identification is really the linkage where it happened between the supply chain and the health information system. And having the standardized product identification will help establishing this linkage. Next slide. And this is the last slide. So thank you and looking forward for question discussion. Thanks.
Thank you so much. Could we have the next person, Godfrey, please? Yes.
Can you hear me?
Yes, we can, yes.
Okay. Thanks, Rami, for sharing USAIDs and your perspective on supply chain digital transformation. We are really honored and privileged to have our next panelist, Mr. Godfrey Kadewele, who is the Director of Health Technical Support Services within Malawi Ministry of Health. Mr. Director is spearheading the establishment of end-to-end commodity tracking and tracing in Malawi public health sector. to improve generation and use of data for decision making. I'm also really excited because Mr. Kadevele, he's here with me in person. Over to you, sir.
Thank you very much. Good afternoon, everybody. So,
yeah, can you hear me? Yeah.
Yeah, okay, thank you. So this is from Malawi, and Malawi is really a country that is sandwiched between 4 countries: Mozambique, Tanzania, Zambia, and Zambia, and Mozambique, I should say. And if you can see from the slide, I think Malawi is a small country, but by comparison, I could also say it's densely populated, because you cannot say the population is 21 million at least. So basically, from that angle, it's densely populated. And the healthcare mostly is supplied from the public sector, as you can see the spread of the health facilities. And I think your attention should be drawn where we've actually said CHAM and government, because those are the main players in the public sector. So Malawi, as far as the supply chain is concerned, is actually going under major transformation. And basically it's actually prompted, the transformation is prompted by the challenges that are actually being shared with you on this slide. And they include low data quality, and then lack of data availability, poor visibility of order flow, lack of data sharing across supply chain systems, and poor inventory management. And I would also want to actually share from the presentation that was just I presented just earlier, we can actually deem that Malawi is not really alone in this kind of problems. That's why we're also going to transformation. Now, in our transformation, we are first of all embarked on a master supply chain transformation, which is running from 2021 to 2026, and is very comprehensive over the 6 years as a roadmap. It serves to leverage the gains made to date and to support the achievement of supply chain integration. The master plan takes a holistic approach by focusing on 9 key areas, which are actually shown in the pie chart on your right. And the implementation of the strategy will contribute to realization of the Ministry of Health mission and vision, which are given below. The vision here is a constant and uninterrupted supply of high quality, vital, and essential health commodities for the end users of the public health facilities in Malawi. And the mission is to contribute to improved health of Malawians through equitable access and national use of good quality, safe, efficacious medicines and supplies at affordable cost, with particular attention to vulnerable sections of the population, which include children, women, and the poor, and through well-trained, motivated, and dedicated personnel. Now, to do that, we have to actually embrace data exchange and standardization initiatives. So the presentation that was given earlier, I think makes my presentation to be understood much better. So in here, we're actually looking at issues of interoperability layer based on open IH framework in the development to allow the similar systems to share data automatically. And also a master health facility registry, which was also mentioned earlier, has been established, and this will serve as the one true guide of standardized health facility information in the country. We're also embarking on master health product registry, which includes standardized country product codes and associated information. Also, they included this national product catalog, which provides the key linkage between the registries, that is the master health product registry, and globally standardized identifiers such as GTINs that were just mentioned earlier. Then the national product catalog, a mobile app, was also recently rolled out to enable access to standardized product details through scanning of JS1 based barcode labels on commodity packages. In the very same vein, supply chain information systems are also being looked at, and an assessment is ongoing to align with the master supply chain plan as a holistic maturity assessment of supply chain information systems was conducted in June 2021 using the supply chain information systems management models tools. The assessment helped to identify supply chain information systems areas that needed attention and improvements. The outputs with assessment is a key input to drafting Malawi digital supply chain strategy and architecture currently under development. The digital supply chain strategy and architecture will incorporate supply chain information systems priorities outlined in the Malawi Master Supply Chain Plan, also mentioned earlier. We also go for integrated digital supply chain, as mentioned earlier in the presentation, in order to yield a patient-centered integrated health commodity supply chain, as envisioned in the master plan. An integrated digital supply chain is essential. The holistic approach, such as using supply chain information systems management model, is helping identify critical supply chain information systems improvements that will ensure well-coordinated systems-driven processes. Standardization of processes and data that are critical foundations are prompting the ability for the separate systems to interoperate. So on your right, you can actually see the diagrams for looking at. Key in there is also the importance of interoperability. From the bottom, which is really to look at the transformation components, going all the way to the dashboard at the top, which is really one I'm interested in as a decision maker. Also, collaborative digital health ecosystems for the future, which we're also very much aiming for. The digital initiatives such as interoperability and master data management that are guided by strategies such as the master plan mentioned, are aimed to take Malawi towards a collaborative digital ecosystem where supply chain systems interoperate and drive processes in a coordinated and consistent way. Also, supply chain ecosystem interoperates with other ecosystems, such as health information systems, regulatory and insurance, to provide a true end-to-end visibility and collaboration. Thank you.
Thank you very much. Thank you very much, Mr. Director, for that informative and insightful vision for digital supply chain in Malawi. I would like to now introduce the next distinguished panelist from Pakistan, Dr. Rana Muhammad Safdar, who is a medical doctor holding a master's degree in community medicine, public health, and field epidemiology. He is currently serving as the Director General Health of the Ministry of National Health Services Regulations and Coordination. We are really, truly honored to have Dr. Safdar on this panel. We also have from Pakistan, Dr. Muhammad Tariq, who is a health system supply chain policy and technology practitioner. He's currently the country director for USAID Global Health Supply Chain Procurement and Supply Management Program in Pakistan. Dr. Tariq and his team have made excellent progress in implementing and maturing key digital assets in Pakistan. So we look forward to hearing from both of you, sir. Over to you. Thanks. If you can please unmute Dr. Rana Safdar and Dr. Tariq.
Thank you, moderator. I hope you can hear me.
Yes, we can hear.
Yeah, so it's Dr. Rana, and thank you for the introduction as well. It's a great honor actually for me to be with all the wonderful colleagues. So I'll just take a minute or two, and then my colleague Dr. Tariq is just going to take you through our country's experience. But let me start by commending the organizers of this wonderful interaction. I think this is not only important and critical for the stronger health systems across the globe, but also I think extremely timely. COVID has clearly taught us few lessons, and to me, two of the big lessons that we all need to learn and build upon is that number one, stronger systems are absolutely imperative and a strong must in routine, as well as if we have to tackle emergencies like COVID in future as well, which of course is going to happen definitely. Secondly, technology is no more a luxury now, but a necessity for the public health systems in developing countries. So as some of our earlier speakers spoke about cultural shift and the mindset change that needs to occur, I think that's critically important. But we also have great opportunity. I think the environment that we are seeing today because of COVID and the role that technology has played in terms of helping the nations in tackling this great challenge in itself has created an environment from which we all of, I think, public health professionals and my colleagues who are for digital health transformation, they can really benefit from this environment. But in order to fully benefit from this environment, I think stronger partnerships that are must. I think that's the key to me that I would like to share with all wonderful colleagues. And again, big thanks from my side, and I'll hand it over to my colleague Tariq to take you through some of the slides.
Who is your colleague so that we unmute?
Sarup, can you unmute me?
Okay. Yeah.
Oh, okay. Thank you. I got it. First of all, my thanks to Dr. Rana Safdar. I mean, despite the fact that he's busy for the next meeting with WHO, very privileged to have him give the remarks in terms of how digitization and digital transformation is necessary for different countries. And it's not the luxury, it is the necessity. Absolutely right, actually. So Dr. Rana is basically leading the COVID response in Pakistan. And just to, apprise my audience, Pakistan is a country with almost, 222 million people. It is a large country. It has, 5 provinces and regional governments and more than 130 districts across the country, and big, primary healthcare services around the country. Now, my talk is basically very briefly, I'll be touching upon, the partnership, as Dr. Rana alluded to, between the Government of Pakistan, Ministry of National Health Services, and the USAID on supply chain management, and how it is actually helping out the digital transformation in terms of digitizing vertical supply chains, and how that is impacting the lives of the people, actually. And I think I would really like to thank Rami, who is globally leading the digital transformation in many countries from a supply chain perspective and health systems. And there's a digital health and interoperability working group that we are part of. I think these are all very good developments where Pakistan is participating as to how we can transform in digitizing health institutions and also institutions beyond health, so that our response to connect public policy with people in terms of products and services becomes more meaningful, to change mortality and morbidity scenarios for different healthcare areas, actually. Next slide, please. So I'll take you to, LMIS, and this has been an unprecedented partnership, not just, the Government of Pakistan and USAID, which started with LMIS, Logistics Management Information System for contraceptives. And as I said, that I'll be actually taking my listeners and audiences from, how that digitally transformed system back a few years ago is actually leading into changing the paradigm of COVID management in emergency situations, which is the topic of our discussion, actually. So this system, as you see, it was launched, by the Prime Minister of Pakistan. This is a government domain hosted with National Telecommunication Corporation, Ministry of Information Technology. The partnership has trained more than 11,000 people. There are more than, 27,000 reporting points, with a number of, supply chains, starting from, family planning to EPI, and then, MCH, and now COVID, and getting into infectious diseases and, other priorities. So if you see, back in 2011, if you go, put your eyes to left, lower bottom, you will see that, it was all very manual system that Pakistan was actually looking at, But now it is all transformed, and data visibility that actually brought a lot of governance and accountability to healthcare systems in Pakistan, where public policy vis-a-vis supply chain is now connected to health products, was actually shifted in terms of how it can be looked after for COVID, actually. So this system, next slide, please. So this system has a maturity in terms of how it is using artificial intelligence, and machine learning in terms of how we are using, control towers and making, information visible to different specific audiences, like, the ministers and the secretaries, the bureaucracy and technocracy, and the district health authorities where information is required in terms of its different needs actually. So demand and supply planning, executive dashboards in terms of planning, forecasting, and financing, all these things are part of the transformation that Pakistan has been actually leading, and government of Pakistan has been actually cooperating its coordination in partnership with USAID. Next slide. And I'm also very thankful to third-party evaluations, like Rami and Kevin at USAID Washington level and regional levels, where we have been able to see what does it means to maturity of the system. Going from an unorganized supply chain systems to relatively organized, and then mature or organized systems, where we are looking at interoperability with different systems and DHIs and others actually. What does it mean actually? So you can see in the slide, this was a multi-country analysis, and we have been able to see maturity coming as a very important feature in terms of use of technology and flexibility of the platform, which can be used for different systems. As Mr. Rami Girgis said, that interoperability is most important in terms of vertical systems talking to each other for a journey that actually has an integration in the long run for the horizontal integration and digitization. And that actually goes hand in hand. Next slide. Pakistan was very privileged again, not only that we have been able to digitize and use technology for different vertical supply chains, and now it is getting into horizontal, care systems. But we have been able to also publish this data, and Pakistan was able to use the data for the last 10 years to see what does it mean that the majority of technology and information systems has leveraged supply chain systems performance in the country. Next slide. And when I speak about the performance of the system, Pakistan feels very privileged, and I know many countries in African region where we are still struggling in terms of domestic financing as to how our supply chains become more sustainable, and domestic financing take its toll to make sure that the host countries' taxpayers are contributing to the long run sustainable systems and financing. Pakistan has been very privileged in terms of allocating $136 million, and that comes from the majority of the system itself. So just an example of a vertical system, the contraceptive LMIS of Pakistan, which is, as I said, being reported monthly by 27,000 transactions for products of more than 7, in number at different health facilities of the country, are actually collecting and collating that data that actually leads to, an evidential, procurement and strategic planning by the government, by the federal government and provincial governments. They are allocating money based on the data of the, information systems of supply chain that perform. My last slide, next slide, please, Saru, is basically my take, and message to my audience and my other countries, where we have been talking about, what does it mean that we can barter technology to other parts of the world where systems can actually, with minor, adaptation and modification, can actually lead to the global, interoperability between services, logistics, and surveillance. And I think that is what we are aiming in the future, that, irrespective of the fact that how complex our countries are in terms of its administrative arrangement of, health care management, in terms of, union councils or counties or districts and provincial governments and national government, and the number of stakeholders operating with their own priorities of different health systems like DHIS and DHIS, or, other vertical systems like lady health workers and community-based, information systems, or emergencies systems, or IDSR and others, where multiple stakeholders have their interests. But the bottom line is that how we speak the language of the host government that we are working for. And I think Pakistan is doing a wonderful job in terms of Dr. Rana and his team, leading that a multilateral and bilateral coordination in Pakistan. We just had a meeting yesterday where, it was realized that, how that LMIS is actually a logistics management system that has actually made a journey from vertical systems to horizontal systems, healthcare system of Pakistan is actually, going forward hand in hand with other fragmented information systems that will actually bring visibility to surveillance data, health services data, and health logistics data, to work out a meaningful, management, healthcare management and financing and administration and other aspects of data utility at the health facility and last mile level. So this is what I wanted to present, in my time. And I think my key message is that technology digitization offer a quick solution. But if digitization is not accompanied with domestic financing, we're not going to go to a sustainable journey of information systems. So I'm very thankful to the government of Pakistan. I'm very thankful to USAID. I'm very thankful to multilaterals operating in Pakistan like UNICEF, WHO, and Gates Foundation, and Gavi for working closely with the Ministry of National Health Services and speaking the language that government of Pakistan would like to lead in terms of transformation and digitization of healthcare system in Pakistan. Thank you very much. Saru?
Ruth, do we still have any presenters? Hello, Ruth?
Thank you. Thanks a lot. Our final panelist, I'm pleased to introduce our final panelist from Rwanda, Ms. Edith Munyana. She's a digital health specialist from Rwanda Ministry of Health. She has over 15 years of experience in health systems management. She has extensive experience in delivering value and innovation in health technology, most recently systems for COVID-19 testing and vaccination. She'll be sharing with us some of the progressive initiatives that Rwanda has been spearheading, maturity assessments and standardization efforts. Over to you, Edith. If you can please unmute Edith Munyana.
Thank you, Mr. Saru. Thank you, the previous presenters for great presentations shared. In Rwanda, we're in the digital health transformation journey, as many of you have expressed, and it is an exciting journey. And one of the presenters mentioned, COVID just showed us how very much we need to enforce this, and everyone needs to support this move. That if we didn't have any underlying backbone infrastructure and digital health applications in place, we'll have suffered even more with more limited access to health facilities and healthcare providers. In the digital health transformation journey, as Rwanda, we started changing the course of how we've been doing things, and we developed health data interoperability standards that defines which standards should be followed by health systems development partners or development in the health data development space. And in those standards, we put down which standards should be followed, how should data be handled, which ones are personal identifiable information, how should health data be protected, and all those standards have been put in place, and the standards are in place. And then we moved forward to the HIE implementation, where we put a health information exchange that has mainly registries that national product catalog belong to. And those HIE registries include, but not limited to, the client registries, the facility registry, the shared health record, and the terminology services, health worker record, then the national product catalog. Previous slide, please. Sorry. Yes, thank you. The main supplier starts with a central warehouse that is called now RMS, or Rwanda Medical Supply, and it is interlinked with our private suppliers like Bufma and any private suppliers in this that provide medical products. Then this distributes directly to 30 pharmacy districts, district pharmacies, and that 30 district pharmacies dispense to our health facilities, to 50 to 546 health centers, to 914 health posts, and of course the 60,000 community health workers. And for us to manage this, we have put in place digital systems, tools like logistic management information systems, LMIS, but next please. Next, please. I pretty much talked about this slide, so I'll go ahead and go to the next one. Yes, the supply chain information assessment informed us that we really needed the NPC, the National Product Catalog in Rwanda. The assessment, the maturity assessment that was performed in 2019, the supply chain information system maturity model, and the outcome showed us that we needed to come up with a national, that we needed to develop a national product catalog that was developed and implemented in 2020. Next, please. Before the NPC was developed, we had a lot of, should I say, duplication of same products in different systems named differently. An example given here is where you find a same product named differently in different systems. Where, let's say, this medicine called Rumentanthrin was named in one of our premises registration information management system as COLAT. And when you go to the second system that manages our warehouse management system, the ELMIS, it is named differently. And in DHIS2, or our Rwanda Management Information System, it has a different naming. And by the time you want to recall this medical product, you recall one and the other named differently, yet it is one product that will remain on the market. And we had those challenges that we needed to address by developing the national product catalog. Next, please. Again, we looked at it and thought we wanted to bridge the gap between the client, our client, who is a patient, or the health facility, and the central warehouse, or where the national product catalog is located. And we came up with a development. We are targeting. We have started developing the mobile application that will help to do the traceability, to track the drug from the manufacturer. Here with the mobile app, the client, let's say at the point of entry, where dispensing takes place, you're able to scan the drug and identify if it's identifiable in the national product catalog or not. We are able to scan and know that this medical product is either counterfeit or not known on the Rwandan market. It entered illegally at the point of dispensing. Even the client who has bought the medical product is able to scan the barcode, or scan with a QR code, is able to scan and know that this drug is a counterfeit or not, is known in the National Registration Authority, which is Rwanda Food and Drug Authority, that registers all the drugs that comes in Rwanda and licenses them. Also, even at the point of entry where the drugs enter also they are able to scan these drugs and be able to know that by the time these drugs reach the either airport or at the entry point of our country, they have gone through all the requirements to ensure that we have eliminated all possible counterfeits. Next, please. So far, we've started the exercise to continue updating this national product catalog. Close to more than 300 drugs have been these drugs have been cross-checked and standardized following the GTINs, and they have been marked with the product identifiers, national product identifiers, and a harmonization exercise goes on, and we work with all the medical stores in country, and we have put out a requirement now to ensure that all suppliers of medical products to Rwanda follow the standardized way of including all the data regarding the GTINs, so that we know all the details to this medication. On the technology part, we've rolled out the NPC in country using a product catalog management, and it is an open source that we customized. We are lastly on the people, we are working on a comprehensive SOPs. We have developed them to standardize product master data management process and establish a catalog manager role. We have established a catalog manager role to facilitate the product master data management centrally at the Ministry of Health. We are working on establishing a data guidelines and policies to ensure sustainable sourcing of standardized master data from manufacturers. Next, please. We continue the journey to transform digital.
Edith, sorry to interrupt you, but if you could kindly wrap up in just about 1 or 2 minutes. Thank you.
Thank you very much. We continue to transform the digital health. We are improving our electronic medical records and ensuring that the dispensing part that is done in our electronic medical records pulls data directly from our warehouse management information system for the drugs. And whenever dispensing happens, it informs the upper part through the integration that is happening now. And it is a journey that we are continuing, and we believe with lessons learned from these sessions and partnership with different partners that have been supporting us in this exercise, USAID inclusive, will get there and even more further. Thank you very much for your kind attention.
Thank you. Thank you, Edith. Thanks for that. I don't know if there are any questions. I'm not able to see the chat. If you have time to take any questions, please let us know.
Thank you, Rup. I think there are no questions at the moment, but I believe people are still internalizing the presentations. Thank you so much to the presenters. We will request that if you have any question, please post it in the chat. We will have a question bank, which we will share with the presenters, and the presenters will be able to give an elaborate answer to them, and we will post them on the website. Thank you so much. We will go straight ahead into our next session. Where we shall be having a presentation from on the pathways to increasing trust in public health data, and an exploratory analysis of community health work collected data. Thank you. Over to you.
Thank you very much. I'll just be sharing my screen. If you could just indicate to me that you can see this, please.
Yes, we can.
Great, great. Thank you very much. All right. Well, without further ado, hello, everyone. Good morning, good afternoon, and good evening. On behalf of DataKind and our consortium partners, I'm really honored to present at this Pan-African Health Informatics Conference. So again, just thank you so much for joining us. My name is Mitali, and I lead DataKind's portfolio of work to apply data science to strengthen frontline health systems. Today, I'll be sharing with you our study of data quality conducted on routine primary care data collected by community health workers using the Community Health Toolkit platform, or the CHT, in one of their deployments. I'll share the goals of this work, key findings, and the potential there is to really automate solutions to facilitate the remediation of data quality issues, and of course, recommendations as well for the design of a data integrity toolkit. Before I begin with that, let me briefly introduce you to our organization. DataKind is a global nonprofit organization with a mission to really harness the power of data science and AI in the service of humanity. DataKind has been in the business of bringing together technologists, subject matter experts, and mission-driven organizations to develop transformative data science, machine learning, and AI solutions for social impact. And we've been around since 2011. All right, so why did we focus on improving data quality and trust? I think we can all probably agree that data is really revolutionizing how people access health services, and that the underlying data quality is important. There is such potential now to use routinely generated data to provide timely care, or even target more precisely specific health interventions based on predictive analytics. But predictive algorithms can't really do their job if the underlying data is problematic or considered untrustworthy. And while there's evidence that community health worker data is often considered, not high quality enough, the methods and approaches to improving data quality are highly resource intensive and often rely on sort of case-by-case judgment by data analysts. And finally, data quality in itself isn't everything. Users must also trust the data. This is what, at the end of the day, underpins safe, reliable, and equitable data-driven care recommendations. The idea of poor data quality as a vicious cycle is probably something that many of you are familiar with. It's when you have inconsistent or some kind of problematic data created somewhere, and it leads to a sort of mistrust or a lack of data use. That in turn leads to disinterest in remediating the problem, which in turn, and especially over time, leads to a sort of lack of data-driven explanation as to what should happen. And neither the nature nor the extent of the problem gets figured out. And that leads to the continuing generation of problematic data, which really worsens the situation. Breaking this vicious cycle is a matter of great urgency. When lack of data trust becomes the norm, it can really impact decision-making throughout the whole health system, particularly in places where community health services account for a majority of primary care visits. So this is essentially the crux of the problem that DataKind has been working on. We hope that by improving data quality in routinely collected data, this will lead to multiple opportunities, such as creating tools that can be used in conjunction with digital health platforms, both existing and new ones, developing workflows that allow people closest to the data to understand the issue and respond to it, and really enabling that deeper analytics to improve the precision of care that people receive. The foundation of our work here is based on the CHT community's priorities, which are essentially to advance universal health coverage, build open source software, invest in open access resources, and practice participatory and human-centered design. Now, as I mentioned earlier, the intent of the study was to assess data quality at a platform level, as opposed to focusing on specific activities or health focus areas. We conducted this exploration on a deployment of the CHT by BRAC in Uganda through the Community Health Promoter Program. And the de-identified data set that we were working with was quite big, nearly 7.8 million health records, representing the activities of over 4,000 community health workers and covering nearly 800,000 individuals. The data that we analyzed, we used a variety of data science techniques and approaches, including clustering algorithms, histograms, box plots, Sankey diagrams, statistical testing. The tests for IOP, which is, by the way, now my short form for inconsistent and problematic data, were identified using a suite of 160 tests that we internally developed. Just as a quick overview, the exploration revealed findings across multiple data themes. These are, a lot of these data quality issues will be familiar to people who work with data all the time. But there are also, just want to highlight some domain-specific data quality issues that are to do with specific primary care workflows. But we identified 5 major areas for deeper analysis and for systematic remediation, I should say. The first is that IOP data created at one point in an interconnected system can really affect an entire database. This is a common concept, I believe, for anyone working in data. But issues such as this are not fixed with one-off spot fixes and require a systematic approach. We also found that in self-reported surveys, you might expect, like in those surveys, some points to be relatively stable, but we found quite a bit of variability. For instance, consider a household reporting whether it had ownership of a hygienic toilet. We may expect the occasional change in status, but we wouldn't expect it to change very frequently. However, we observe many households for which the responses switch from yes to no or no to yes, practically from one survey to another. This can have potential implications, for instance, for water and sanitation programs, malnutrition programs, and others that rely on these data to provide key interventions. And here remediation could include anything from identifying high fluctuation fields with an aim to stabilize it over time, or even trying an approach of using those insights gleaned to change and improve survey questions. A third area we identified is issues with accuracy, which is a key dimension of data quality. In this case, looking at thermometer temperature entries, we see many outliers, where some CHWs record abnormally high or low median temperatures, which begins to suggest perhaps that some community health workers have miscalibrated thermometers. And miscalibrated tools can really produce inaccurate results, which lead to inaccurate data being captured, even if the actual process of capturing the data was completed properly and successfully. A remediation effort here can be automated and regular reviews to help identify particular instruments that are continually producing outlying results, allowing for timely intervention. A fourth major area for deeper analysis is completeness and timeliness of, in this case, maternal health coverage. This is a Sankey diagram of treatment flows, which shows really that pregnancy follow-ups often go untracked. So in this particular case, we found 75% of pregnancy outcomes were null values or unrecorded, which means that birth outcomes are not being recorded. In addition, we found aberrations to expected workflows. Over 6,700 patients that required a health facility visit did not go, or the data was unrecorded. Data being inconsistently or incorrectly being captured within the sequence could lead to issues downstream, especially in reporting of health system indicators and metrics. Here, the remediation of this type of IOP includes in part community health worker training, but other strategies can be more specific, again, such as improving the form, where in this case, a redesign removes a question like patient sex from antenatal forms. It is a sparsely answered question anyway, and would actually streamline the data collection process to reduce inconsistencies. And lastly, using a cluster analysis and some segmentation techniques, it's a common method to actually track and manage worker performance in many industries. We created 4 preliminary community health worker archetypes. This is non-exhaustive and just exploratory, but these segments start to provide some indications as to how community health workers go about task completion. It is hoped that by creating these archetypes, we could approach a more targeted way of coaching and performance management tasks, and really try to improve task completion rates and adherence to health protocols. Moving into recommendations, and based on our key findings, we've centered these recommendations on a platform-wide approach to tackling data quality in community health. Our first recommendation is really that, I think it's what everyone's been saying here, the actors really commit themselves to the practice that further data science initiatives involving predictive algorithms and other novel approaches of data-driven care really should be built on a strong foundation of systematically tested and trustworthy data. Second, the healthcare sector must move toward a culture of prioritizing data quality and affirming data trust. There is as yet limited development and idea exchange for learning from learning from one another and really automating data quality. A technical community of practice alongside other multidisciplinary expertise needed for such work could really create the systems and standards needed to embrace sector-wide quality standards and testing practices within digital health platforms. In addition, we recommend that health systems should provide ongoing training and support on data quality and target not only frontline health workers, but also supervisors, data analysts, health system managers, and others who play important roles in IOP data remediation. As we noted earlier, exploring IOP doesn't help if we cannot detect it systematically. So our key recommendation is that the pathway to improving data trust is actually the reproducibility of the approach. Our approach here relied on the creation of 160 statistical and performance tests, much of which can be developed into automated processes. This testing, however, can be expanded in important ways beyond, for example, the maternal and health child workflows that were shown, but also to include, for example, information from other parts of the health system, such that a much broader range of IOP may be identified. And we recommend the use of data visualizations and real-time dashboards to really provide a high-level overview of IOP trends and allow community health teams to monitor changes in IOP over time, even across multiple locations, such that we can drive practical and thoughtful conversations about IOP remediation. And lastly, it is important to identify opportunities in software such that we can really prevent problematic data from being created in the first place. So rather than waiting for, for example, an IOP test at a database level to be identified and to create reports, actually proactive rules can be built into health forms that would not even allow specific problematic data to be captured. Our study has really shown that there are several opportunities to disrupt the vicious cycle of data quality issues, and the pathways for improvement actually lie at a platform level. In fact, the study's results can be interpreted to be recommended as almost platform agnostic, given the similarity of data quality issues felt across platforms, geographies, deployments, and in fact would be most impactful when operating within existing healthcare management tools, such as the CHT or even DHIS2. Encouragingly, a significant number of remediation pathways can also be generalized. And to conclude, I think I'll just say that this study aimed to really provide results, discussion, and recommendations towards the creation of a toolkit for auditing data quality and increasing data trust across health data platforms. Our hope is that when it's in use, it expands the capabilities of health platforms, such as the one being developed by UNICEF in partnership with the Rockefeller Foundation, and Living Goods Consortium in support of Uganda's Ministry of Health and the Village Health Teams program. Well, I'll stop there. Thank you so much for your time and attention. And I'll close with a thanks to our many partners and collaborators whose vast expertise and experience have guided our work. Thank you again, and I'll stop my screen share.
Thank you, Mitali, and everybody who has presented this afternoon or this morning on your side. It has been a very insightful session, and we thank everybody who has been able to participate in this this after lunch session. We encourage everyone who has listened in, and if you have any answers, please post them in the chat, and our presenters and panelists will be happy to respond to any issue, query, or clarification that you might want to be made. Thank you. So right ahead, we will be going into our breakout sessions. They will be, we'll just take one, how many? Like how? So the breakout sessions will be strictly 15 minutes. So we would like to encourage our presenters in those sessions to please keep it and be within the 15-minute window. So the rooms are open. Please go ahead. Please go ahead. Room A has assessing knowledge and practice of e-tracker among nurses. And then room B will have e-health architecture-based health data exchange for Ethiopia. Thank you. I wish you a fruitful deliberations. Thanks. Okay. So for breakout room A, Steve will support with the moderation. Then Joe and Nakibuka will be supporting room B. Thank you. Please move to the different rooms so that we can start. It's now 13 minutes into the session. We've lost about 2 minutes now. Please move to rooms A and B for the discussions. This is the main room. This is the main lobby. Please move to room A and room B. Look in the below. Below your screen, you'll find there the breakout rooms. Thank you very much for attending this session. We'll go right ahead into the next session. In room A, we have implementation of continuity of care to diseases, duplicative drug dispensing at HIV clinics in Haiti. And in room B, we have advancing site-level health informatics capabilities using a maturity model. Yes. Thank you. The sessions are 15 minutes each. To be useful if the presenters can please keep time and give people to ask questions. Thank you. Yes, the rooms are just going to be opened shortly, please. They are now open. Please move into the rooms. Please move to the breakout rooms. We have Welcome back from that session. Sorry for those who are still enjoying the previous speakers, but unfortunately, we encourage the speakers to keep time in their presentations. We will go right ahead into the next presentation. Um, Developing a systematic procedure for strengthening routine immunization data quality. And then in room B, we will have yeah. And then we will have a novel Kenya EMR implementation. Hmm? Sorry, it is strengthening in room A, there's strengthening capacity of government workforce. And then we have implementing an adaptive low-cost knowledge integration platform in room B. Please go ahead and join the rooms for those sessions. Thanks. Please move to the main room, those who are still in the main lobby. Move to rooms, to the breakout rooms if you're still in the main lobby, please. Thank you all for attending the session. We are now getting to our last breakout session. Yes. Room A has a developing a systematic procedure, and then room B has a novel Kenya EMR implementation to scale up for TB. Thank you.
This is 20 utilization interviews and quality by developing systematic procedure to compare data from both sources. This data is
Alvin.
So what's the methods are and focusing on capacity renting and job training for amenities. So the first setting place to actually
Thank you everyone for your patience and participating actively in the breakout sessions. We are nearing to the end of the sessions. We're just remaining with one. We would like to apologize to the team that was interested in the presentation in room B. Incidentally, our presenter was unable to, was a no-show, even though the presenter did manage to confirm in the morning that he was going to be. And it was evident. You could have seen a gentleman called Luaka, who was always coming on and on. But given that it's a virtual, you cannot control someone who is not physically there. So we sincerely apologize for that. We would like then to thank you again and request that we go to the last session, which in room A, we will have the interim analysis of government staff capacity. And then room 2, we'll be having an open MRS 2021 by Grace Bodmer and team. Over to you, the Secretariat. Thank you.
Thank you, everybody, for the patience, for the participation, for keenly following the proceedings of the day. We would like to thank our presenters, our moderators for the different sessions, the breakout rooms, our participants who have been very, very, very passionate, who have been very interesting, asking the questions that are thought-provoking. We would like to thank our secretariat in Kampala, who have been able to make this day a grand success. Thank you so much. The presentations will be posted on our website. We encourage everyone, please go in, read, understand. I know that the presentations have references. It would be good to go to the references and get more insight about the presentations. And so we've come to the end of today's sessions. However, there is an event by Helena, which is the Helena Assembly. We would like to encourage you to stay around and listen in and see what to learn also. And the board will then definitely be closing today's sessions and today's end. Over to you, the board, Helena. Thank you very much. Okay. For those who have not sent the presentations, please do send them to the secretariat so that we can post them on the website. And if you still have any questions, please do write the questions and we will definitely put them and share them with the presenters, and the presenters will go ahead and give elaborate answers to them. Thank you so much. Over to you, the board of Helena Board. Thank you. Tom, please go ahead and start. For us, I think here we have given you the opportunity to go forward with the conference.
Okay, just good afternoon. Just give me 1 second to load my slides. Just 1 second.
Hello, Tom. We can't hear you here. Please speak and we hear. Maybe your volume or something. Thank you.
Hey, okay, yeah. I'm just trying to load my slides, yeah? Just give me one. Can you hear me? Hello?
We can hear loud and clear. Please, go ahead.
Okay, just give me 1 second to load my slides.
Okay.
Can you see my slides?
Yes, Tom, we can see your slides. Please put them in presentation mode so that we can.
Okay.
We can see. Thanks.
All right. Yeah, thank you very much. Good afternoon, good evening, good morning, everyone. Welcome to this session where we're going to share with you a little bit more about Helena, the association. And the main aim of Helena is promoting, the main title for my talk is about promoting evidence-based health informatics in Africa. And my name is Tom Oluoch. I'm the current president of Helena. I'm going to guide you through this presentation, and hopefully we can have a Q&A session at the end of this. But just before I get started, I wanted to just quickly introduce the Helena board members who I think should be on the call. So I'll start with myself. I hope my other board colleagues are on the board on the call as well. So like I said, my name is Tom Oluoch. I'm the current president. In my day job, I work for the US CDC. I'm currently based in Rwanda. My home association is the Kenya Health Informatics Association. So I'll hand it over to the president-elect, Frances Baba, if she's on call. Baba, if you can just introduce yourself.
Good afternoon, everyone. My name is
Sorry, Baba, your line is breaking up quite a bit. We didn't hear you. If you could mind.
I am the president-elect for Helena, and for my day job, I'm a lecturer at the University of Ghana School of Public Health. I'm the president-elect for Helena, and currently I work as a lecturer at the University of Ghana School of Public Health. Over. Thank you.
Okay, thanks, Baba. And then over to Steve.
Thanks a lot, Tom, and good morning, good afternoon, good evening, everyone. My name is Stephen Onye. I'm the secretary to Helena, the board of directors at Helena. As Tom mentioned, I'm also a member of the Kenya Health Informatics Association. I'm actually the secretary general, serving on the leadership of care here alongside with Dr. Tom Oluoch. My day job is I run a company called Intelsoft Consulting Limited. We are based out of Nairobi, and we basically develop software solutions for the health sector, mostly working and developing on top of global goods. Really happy to be here and looking forward to interact with all of you. Thank you.
Thanks, Steve. I know we had apologies from other board members, but I just wanted to check if there's any of them. If either Ghislaine or Innocent, if they're on the call, please introduce yourselves.
Tom, I can't see either of them on the call.
Oh, okay. Thanks, Steve. So yeah, so we have apologies from two board members, Dr. Ghislaine Kwemachua, whose home association is Cameroon Health Informatics Association. He's based in Germany. He's the past president of Helena. And the other member who sent apologies is Innocent Nanan. Dr. Nanan is from Cote d'Ivoire. And yeah, he's our current treasurer of Helena. And later on, I'm going to present a slide that mentions them. Okay, thanks very much. So I'm going to go ahead and share this presentation. So first of all, just talking a little bit about Helena. Helena is the Pan-African Health Informatics Association and the African Regional representation of the International Medical Informatics Association, that's EMIA. And Helena was founded in 1993 in Nigeria. And the primary purpose was to promote education and research in health informatics. And then also just ensure ethical and modern and evidence-based e-health projects are implemented in a way that enhances quality of care in Africa. And Helena subscribes to EMIA's vision, where it says there will be a worldwide systems approach for healthcare. That's a vision that EMIA has put out there and they're working towards. and EMEA subscribes to that. Helena subscribes to that same vision. And Helena holds the annual scientific conference, which is what we are attending this week. Participation is usually anything ranging between 150 to 200 participants. And they usually include an all hands-on pre-conference workshop. And this year is a very unique year because actually Helena's conference was supposed to happen last year, hosted by the Uganda Health Informatics Association. But because of COVID, it had to be delayed to this year. And this is the first time that Helena conference is taking place virtually. We are learning a lot of lessons from it, and hopefully that will inform how the conference run in future. So for those of you who were able to join the pre-conference workshops yesterday, you are familiar with it, but that's not the format that we typically use, because as you know, pre-conference workshops are hands-on in nature, and they tend to take like anything between 3 hours and half a day, or some of them take a full day. So in the 2019 Helena conference, which was held in Gaborone, Botswana, we had 3 workshops featuring data science, application of use of drones in public health, and then there was another session on scientific writing. So again, very successful workshops that were very well attended. So to Helena's vision, our vision is quality healthcare for all in Africa, transformed through health informatics research, development, implementation, and education. And the mission, as you can see there, is just the expanded version, but most importantly is about providing a meaningful forum for health informatics research, development, implementation, education, standards development, and technology adoption for the African region. So this is the composition of the current board. As I said, I'm the current president. My term started in 2018. It was supposed to end last year, but because we did not have a general assembly, because there's we didn't have the conference last year, that was pushed to 2021. So my term is actually ending next month. So, we have the president-elect, Francis Baba da Costa Vroom, who takes over as the president starting next month, which is, so in 2021. And then the current secretary is Steve Wanye, whose term is running from 2018, was elected in 2018, runs through 2022. And the treasurer, like I mentioned, is Innocent, whose term is from 2018, runs through 2022. And the past president, who unfortunately couldn't join us today, is Ghislaine Kwemachua. He's the one I took over from. He led the association until 2018, when I took over from him, but he still participates on the board as a past president of Helena. So this is just the governance structure. As you can see, I'm not the best artist, but at the top we have the Helena board, and these arrows are not supervisory by any way. They just like kind of showing they're more relationships rather than supervisory. So it's not an indication of something hierarchical in any sense. They're all just how the different entities relate with each other. So as you can see right there at the top is the Helena board, and Helena board is connected with the working groups, and I'll talk a little bit more about the working groups. And then there's the national societies, and then the collaborating institutions. And again, in the next slide, I'll show where the national societies are and where the collaborating institutions are. So let me start with the working groups. There are 3 working groups: the education working group, the standards and interoperability working group, and the data analytics working group. Of these 3, the education working group is the most vibrant. As you may have heard earlier, for those of you who attended an earlier presentation, it's the most vibrant. We are working towards ensuring that all working groups are functional and are active. And the way to get this working is through people stepping up with activities and with the time to come in and work around projects that promote the work of these working groups. So if you go down to the bottom, there's the individuals. So individual members can belong to any of these working groups. So you see the arrow from the individuals to the left, pointing how individual members can join any of these working groups. But at the same time, from the individuals, the arrow pointing up shows that individual members can belong to national societies. and they can also belong to collaborating institutions, which then are affiliated to HELENA. So HELENA does not have individual membership, but is made up of national societies. Actually, the membership of HELENA is national societies or collaborating institutions, not directly individuals. Individuals interact with HELENA through the working groups. So hopefully my diagram makes sense. Yeah, like I said, I'm not the best artist, but I try to give it my best shot. So just talking a little bit about the working groups, the education working group focuses on building capacity building initiatives, and that's where its focus lies through pre-service education activities related, including curriculum development and so on, and then also applied training or training on the job on health informatics. Then the standards and interoperability working group supports countries to establish standards and policies on health information exchange, and also exchange experiences in implementation of open standards. And one of the ways we've engaged also, and I'm going to talk a little bit more about our engagement with Africa CDC, we've been directly involved in the standards and, developing standards and policies for health information exchange. And that's like an activity that we see falling squarely under our standards and interoperability working group. And then we have the data analytics and big data working group, which mainly focuses on application of artificial intelligence or machine learning for advanced data analytics and modeling. And this is an area where we welcome you to participate, to contribute, and just to be sure that we keep these activities active, or each of these working groups active. Then coming down to HELENA membership, we currently have 12 members. These are national societies. As you can see, the ones listed, the ones in green are the current members of national societies that are members of HELENA. There are 12 in number. The names appear on the right. And then we also have collaborating countries, nine of them, which appear here in blue. And just to clarify, the collaborations are either through ministries of health or individual universities that would like to be associated with HELENA. And those are mainly in countries where there's no national society. Because like I said, the primary national membership of HELENA is through national societies. So some recent activities of especially, let me talk about the education working group. They did some work with the harmonization of curriculum for masters in health informatics in East Africa. And that is an activity, I think, that happened last year. There's also development, online tools for capacity development and collaboration. And then there is other activities such as GIGS, which is the Growing E-Health Expertise and Knowledge. That was done, some work that was done in collaboration with the US CDC. And this is an approach where there's kind of intense one-week training, and then guests go back and take real life projects, implement them, and then present them at some point. And this is really very hands-on tech training as a way of building capacity on specific digital health technologies. Then there's the annual conference, which is currently going on. And as we know that the papers that are selected, the full papers that are accepted for presentation are going to be published in the Journal of Health Informatics in Africa, which is the journal for HELENA. And then, of course, we're working towards forging stronger community engagement through national societies, through working groups, and through individuals. And a couple of things that I'm going to mention around stronger community engagement are issues around, for example, we have a draft strategic plan and draft constitution, which has been shared widely with membership and has also been translated from English to French, so is equally applicable to the Anglophone and Francophone countries. There's been discussion about translating it also to Portuguese to cater for the Portuguese-speaking countries of Africa. And that's available, I think is in the final stages, ready for launch. There was also engagement of the community in moving. The original secretariat of Helena was in Mali, in Bamako, but through consultation of the membership, the decision was made to move the secretariat to Accra in Ghana. So the University of Ghana School of Public Health is the home host of Helena, but the association is formally registered in Ghana and follows all the Ghanaian laws, including submitting annual audits. We've just recently submitted the audit report for the past year. And this has been going on since Helena was formally registered in Accra, Ghana. So we follow all the statutory requirements of the host country where the Helena is registered. So still talking on some recent activities, I mentioned our collaboration with Africa CDC, which has grown pretty strongly over the last 2 years. So Helena participated as a member of the task force of experts that helped develop the capacity building framework, or the framework for public health workforce development, which focused on 3 areas. One of them was about training epidemiologists for Africa. The second part was the training of lab scientists. And the third part was training health informaticians. So this document is publicly available. That's the link right there, which you can share later on. But even if you search for it, you can find it, and you can see that Helena played a big role in the development of this framework, which, as you know, I mean, Africa CDC is really the public health institution of the Africa Union. The second one was, on the health information exchange. The health information exchange policy and standards document. And yesterday, for those of you who attended the keynote speech by Dr. Justin Maida from the Africa CDC, you remember him talking about the health information exchange policy and standards document that has been developed by Africa CDC and is currently with the member states for validation. I think they've already had one validation visit in West Africa. There's going to be one for Southern Africa and Eastern Africa, and then the North and Central. So eventually, once this is done, it's going to be shared more widely, and you'll be seeing that it defines clearly what some policy and governance issues around health information exchange, including privacy, data confidentiality and security, but also talks about the standards, the open standards that are used for data sharing of health information exchange, especially as you think about individual patient level information that's used either for clinical care or for surveillance. So sharing within countries, but also sharing across borders, especially now as we think about pandemics that span across borders, like the current COVID-19 situation. So if we're talking about tracking testing or tracking vaccination coverage and so on, we need to have systems that are interoperable across boundaries, across national borders. And so that document really well defines those standards. And again, Helena was a strong partner in the development of these policies and standards. And once that document is published, again, we welcome you all to use it widely to inform national policies and standards implementation. Then I talked about the educational working groups activities, including curriculum development and also other ongoing collaborations on capacity building. So our goals over the next 2 years, like I said, strengthening the activities of the working groups through networks and through partnerships with key stakeholders, including academia. Again, like I said, I mean, we partner very close with Africa CDC, but we'd like to work more with WHO and other key stakeholders implementing digital health solutions in Africa. Then there is enhanced participation of national societies in respective country health capacity development initiatives. So we want to engage more with those existing societies, but also want to encourage countries which do not already have national societies to form them and also just be sure that there's networking and collaborations in country, even before you go to the global or regional scene. Then, of course, webinars and workshops and training opportunities for, targeting technical and leadership levels. That's something we're hoping we can work through both the education working group, but also just through other collaborations. And good examples are COVID-related webinars. Just a few months ago, the Uganda Health Informatics Association had some good presentation on a good webinar on, presented the Global Digital Health Network. And so those kind of webinars are very informative. They share experiences and just show what the national societies are doing within their own boundaries. And then also just to enhance visibility and participation in Helena conferences for increased interest in research and collaboration with universities. We really value this, your participation in this conference. It's really, like we said, promoting research and just generating evidence for health informatics activities that are happening in Africa. But you do see that we attract interest and participation beyond the continent, and it's a very good opportunity just to share and learn from each other in terms of best practice and just what works and what doesn't work. So just how can you participate in Helena's activities? The first way to participate is through your National Health Informatics Society. Like I said, if you remember the graph that I showed earlier, how national societies then participate in the activities of Helena. The second way is by joining a working group. The working groups, as you've seen, they're listed right there. There must be something that you have an interest in out of these working groups. So please, we encourage you as members to join these working groups. The strength of the society, the strength of Helena lies with the membership. The more active you participate in Helena, the stronger it becomes. And we really encourage people to participate, and not just participate, but also to, like, when elections come and when there's opportunities to elect new officials, that you step up and be elected, because that's the only way we can strengthen the association. That's how we bring in new ideas to the association. And that's how, because this is really a voluntary exercise that we do, but it also helps you build your leadership skills if you step up and vie for positions when they become vacant through the General Assembly. And also just contributing through the interactive social media tools that are available on the revamped Helena website. We're going to talk about the Helena website in a short while. There's, we had an old website based on, kind of old technology. We are working on revamping it. And I think later on, Steve will be talking a little bit more about it, taking us through it. And it's kind of work in progress, and we're going to really welcome your inputs on improving it and just making it something that works for you. So like I said earlier, if there's no national society that exists in your own country, please plan on establishing one. And we strongly encourage you guys to consider in countries where there's none. Or if there's one that's dormant, you can step up. It just takes a few people who are committed to just turn it around. The initial start may be slow, but don't give up. If you want to learn from other countries that have recently set up their societies, Helena will be happy to point you or pair you up with other countries that can help you and encourage you as a startup to come up to speed and stand up your association. And then also plan to attend the Helena General Assembly, which will be sometime next month. We're going to announce the specific date. And like we said, during the General Assembly, there's a sharing of the report, the annual report of Helena. There's also the sharing of general progress and future direction that the Helena is taking. But more importantly, there's an opportunity to elect new officials. And like I mentioned in one of the slides much earlier, they are outgoing officials like myself. Just at the tail end of my time as president of Helena. So there are positions that are going to be vacant. So we really, really encourage you to step up and contest those positions. We do hope that we're going to see as many of you as possible during the General Assembly. And this is going to be communicated fairly well in advance. So that's my last slide. And I just leave you by saying, let's promote evidence-based health informatics in Africa through sharing of research findings, best practice, and innovation. So that's the end of my slide. I'm going to stop there and maybe just pause for a minute or two if there are any questions that anybody may have. So thanks, and over back to you, the facilitator, and then I'm going to come back if with other board colleagues if there are any questions to respond to. Hello, I hope I didn't lose everyone.
No, we are there, Tom. It's just that we had given the mantle to you to present and also close.
Oh, okay, okay, okay. That sounds good. Yeah, I see a comment here from Dr. Tedese. Yeah, thank you so much, Tom, for your exemplary leadership moving Helena forward. Thank you so much, Dr. Tedese. So perhaps based on an earlier presentation today, I don't know if people had any questions or something they needed clarified, or based on my presentation, if there's something that's you feel you need any clarification on. But maybe as you're thinking, I probably would also give this opportunity to my colleagues on the board, Steve or Baba, if there's anything that you may want to add that I may have missed.
Not much from me, Tom, but just to say that we hope that going forward, we'll be able to have a lot more people joining to get a lot more on board. Thank you.
I need to make a comment. Hello, can you hear me, Tom?
Yes, please go ahead.
Sorry, and I apologize for the background noise. And I think I just wanted to say that I think, Tom, you've covered it really well in terms of what Helena is all about, how Helena works, how to engage with Helena. So I really don't have a lot to add. I think just to mention that with regards to the new website, helena.africa, we'll definitely share. We'll share the live link tomorrow, just for everyone to interact with. We consider this a soft launch, and again, as I mentioned earlier, we're looking at consolidating the really good work done by the Education Working Group on their temporary infrastructure, helenanet.org, and the older website, helena-online.org, into one website, just to make it easy for everyone to interact with Helena. So please look out for that, and we'll share a lot more information tomorrow. Thank you.
Thanks a lot, Steve. Yeah, we hope that we can get your feedback. As you say, I mean, Helena is the association that belongs to all of us who have an interest in health informatics in Africa. So I'd really welcome you, once the link is shared tomorrow, that you take a look at it, try it, test drive it, and give us feedback, and just show us ways that you'd like us to improve it. Okay. So, yeah, I'm looking at the chat box. Yeah, just checking if there's any other questions or comments or thoughts, and suggestions are welcome too. I mean, like I always say, I mean, nobody has a monopoly of knowledge, and we really welcome suggestions and thoughts that people may have on how we can improve Helena. And again, like I said, I mean, if people have ways and thoughts of improving Helena, there's many ways to engage, be on the working groups, or better still, please apply for a position and join the leadership of Helena and be one of those who change Helena and how it does business, and just to inject new ideas, new thoughts, and so on, and also new energy. So I see a comment here from Dr. Sorry, just to be sure that so yeah, there's a couple of comments coming in here. Oh, sorry, I wasn't keeping an eye. Yeah, so there's a question earlier on the handles, the social media handles, if any, and I think Steve responded to that earlier. And again, once we share the links for the new website, you will see here all the social media handles. And someone was asking here about where is the contact in Nigeria. I think Nigeria, we know there's 2 associations. Yeah, I don't have the names off the top of my head, but if you Google Health Informatics Association in Nigeria, I think you'll come up with 2 names, and I encourage you to do that. But we're also happy to just kind of share that information with you later on. And the Steve's email address that's been posted on the chat, you can send an email to Steve Wanye, who's the Secretary General, and he'll provide you further information if you need. And then Dr. Tadese added, I would like to suggest a membership working group. Really need to actively pursue to have all African countries establish informatics association, as well increase attendance by including students on the Helena conference. Yeah, I totally agree with you, Dr. Tadese, about student participation. And we did extend invitations to students to participate, and actually the board made a decision later on to have this as a free conference for students. One of the main challenges was validating student participants, and one decision was to use the student ID. It was not perfect, but one way to just indicate that one is a student. But again, like I said, I mean, this is the first time we're hosting a virtual conference. In the past, we've really encouraged students, and especially the host countries, I've really had a lot of students come in and attend the conference. This is a learning opportunity, and I believe that if the next conference, which I'm hoping is going to be a hybrid conference that's got both in-person and virtual attendance, we can have as many students attend as possible through virtual connection, and just maximize their participation through that. So thanks a lot for that comment. Yeah, and Noah Jaffa suggests, Mr. President, please encourage all members associations to share their Twitter handles and to follow the Helena Twitter handle at HelenaNet. Yeah, so I guess the Secretary Steve has noted that, and also, yeah, agreed on the, yeah, on the suggestion. So that's very well noted, Noah. Then there's a question from Laiton Namutebi asking, how is Helena supporting research in the member countries and around African universities? So maybe I'll start, and other members, please feel free to chime in. So first of all, I think, let me start with the conference, which I think is, as I said earlier, is a scientific conference. It's intended to promote research and promote sharing, and especially by students and also early career researchers who are just getting into research, starting to publish and starting to look for opportunities to share their research. So that's one way that Helena is working on, just kind of giving us a platform to share the research and also for publication. I talked about the Journal of Health Informatics in Africa, GHIA, which is an opportunity to publish your research. And this really gives priority to African people in African universities who want to publish their work out to the outside world. And again, I emphasize early career, which is mainly where the universities, work around in terms of kind of generating young researchers to publish. One of the other things, and I think the chair of the Education Working Group is here, he may also comment on that, is about collaborations with African universities on kind of curriculum development. I'm sure there's an element of research in that as well, in terms of this element of capacity building, training, the curriculum for training health informatics at postgraduate level. And often postgraduate level has an element of research. And the group has worked with some universities, especially I know I'm more familiar with the ones in East Africa, to help promote training and research, or teaching and research at postgraduate level on health informatics. Those are just examples. And again, we also welcome ideas through which we can collaborate and help strengthen capacities of universities around Africa. But ideally, one of the ways, like I said, is to bring networking opportunities to learn from each other and help build capacities in research. So Martin, if you want to add to that, you're very welcome too.
Hi, there's also the journal for
Sorry, Baba, your line is breaking quite a bit. So do you want to start over, please? We didn't hear the first part of your contribution.
Africa, that's jhia.org, jhia/online. Oh, sorry about the journal. The journal for that is, hello?
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 Yes, okay, now we can hear you. Do you mind starting over? We didn't hear the early part of your...
Okay, yes.
Yeah.
So I was talking about the Journal for Health Informatics in Africa. Once you Google it, it's going to come up. So that's the official journal that Helena publications can be found, and also publications from researchers across Africa. So there are a number of articles that you're going to find in there. Currently, there's no article processing charge. So once you send in your peer-reviewed article or manuscript, it will receive a review, and then if it meets the requirement, then you can get published. So those are all resources that Helena has for supporting research. Thank you.
Thanks, Baba. Yeah, thanks a lot. And then Steve has responded to the question on the Twitter handles. Just finalized major infrastructure upgrade. Yeah, so check out the Journal of Health Informatics in Africa as well. So yeah, that's the same thing that Baba was just saying. Okay, I think we've covered most of what I could see on the on the chat. I don't know if I've missed anything on the chat. Yeah, and then I think Martin Were posted a comment on the helenanet.org, just to clarify that it was supporting the activities of the education working group while the new site was being developed. If the new site features the EWD needs, we will transition to that. So I think that I hope that clarifies that point. And then there's a link there on those interested in joining the EWG. There's a form there that you can fill out. Okay, so yeah, I was just still looking at the chat to see if there's anything. And then again, Dr. Tedesi is asking, how can we become members of the working groups? Are they open to everyone? Yes, so as I mentioned on one of my slides, that the education working group really, sorry, the working groups are open to all members. And I'm just going to try and see if I can pull up that slide real quick. So if you can still see my screen. So I mentioned that individuals can either join the working groups, the arrow to the left. You can join any of the working groups directly, or you can participate in Helena activities through your national society or through a collaborating institution like a university or the Ministry of Health. So yes, the short answer to your question is yes. You can approach the working groups directly. And I think for the education working group, there's just been a link that's been posted on the chat that you can fill out a form, and that's how you initiate your membership of the working group. And we'll adopt similar approaches for the other working groups as well. Especially once the new website is fully functional, then you should be able to find more information on how to join the working groups. Okay, so I don't see any more comments. Okay, does anybody have any more questions? I hope that we responded to all the questions that you had, the ones that were posted on the chat. And if you have any more questions, I guess you can unmute yourself and just share. If there's none, then I just want to thank you all again very much. And again, like I said, we are going to send out communication for the Helena General Assembly towards the end of November. And you're all very welcome to participate. And please step up for leadership positions and just participate in helping strengthen Helena. So again, on behalf of the board, I thank you all very much. And also just use this opportunity to thank the Uganda Health Informatics Association for working very closely with us to host this very interesting and very exciting conference. So thanks a lot to the UGHIA, and thanks to my colleagues, and thanks all for participating. Over.
Thank you.
Thank you. Bye, everyone.
Bye-bye.
Bye. Thank you.
Thank you. Bye.